So, hello everybody. It's my great pleasure to warm welcome you here to this ALD AMN session on behalf of the Adrenoleukodystrophy Foundation. This year, I think we'll focus a little bit on the cerebral forms of ALD and AMN. On females with ALD, but also we will address, I think, many other aspects that come from your side. So please ask questions whenever you need to ask questions. But we start now with Dr. Mark Engelin from Amsterdam. He will give us an introduction on the ALD spectrum and the unmet clinical need. I think this is a very important introduction to today's session. Yeah, Mark, it's your turn.
Thank you. Yeah, I think it's working. Well, good afternoon, everybody. It's a great pleasure to be here. And my task is very simple because I only have to give a brief overview to basically provide some backgrounds for the other speakers that will have that can present on ongoing new interesting trials. But first, my disclosures. So we'll be talking about the ALD spectrum. I think most of you are pretty familiar with it. We'll go through it briefly. Then natural history as we currently understand it, and then we'll get to the challenges for the next couple of years. So, clinical features, as you know, ALD, of course, is a disease that is characterized by a biochemical abnormality that is present in all cells of the body, but there are several organ systems that are clinically affected. So that's the adrenal. So people develop adrenal failure during life. That is the white matter of the brain, so people can develop a leukodystrophy. Both of these features almost exclusively in male patients. And male and female patients will eventually develop spinal cord disease that is characterized by a gait disorder and also bladder and bowel dysfunction. And what nobody ever talks about is the predisposition for baldness, but that is also a well-known feature. So these are the core symptoms, but how do they develop or how do they evolve over time? So as most of you probably know, the adrenal insufficiency, so these are survival curves. So on the horizontal axis there is age, and on the vertical axis there's the proportion of individuals affected. So you see adrenal insufficiency is something that occurs early. By the age of 10, about half of the boys already have adrenal failure, and over lifetime, about 80–85% of male patients will become adrenally insufficient. So this is kind of turned upside down. So here the y-axis, here it starts at unaffected, and you see that the leukodystrophy is also something that occurs very often in childhood, but still during life, male patients can still become affected. And for the spinal cord disease, that is something that you almost never see in childhood, but becomes very prevalent in middle age. And eventually, if you become old enough, all male and female patients will develop some symptoms of spinal cord disease. So if we put it all together, with ALD, you never have symptoms at birth. You're always born completely healthy. And during life, there's a high probability of at least adrenal insufficiency and spinal cord disease in adulthood. And some people will develop a leukodystrophy. And we are still not sure why some people develop a leukodystrophy and others not. So there's probably all kinds of unknown factors at play. But yeah, this is of course the things that have been known for a long time. But is it enough to design good clinical trials? Well, no. If you want to design a good clinical trial, you have to have very detailed knowledge on how the disease develops over time, much more detailed than the broad overview we looked at. And to get that data, you need to study large groups, more than one center preferably, and you need that data to determine what would be a good endpoint for your trial, and you also need to do studies to to determine how you can measure those endpoints in a reliable and meaningful way. So for that you need good follow-up. And to illustrate that it's not that easy to get a good idea on natural history, for instance, a few decades ago, it was the impression that if somebody developed a leukodystrophy, like on this scan, the area with the high signal intensity, that it would usually be rapidly progressive over the course of several years. But when more data was gathered, it turned out that many adults that have one of these lesions can remain stable for years or even decades. So basically, we're not completely sure why the leukodystrophy behaves so different in some individuals. And at this time, we're not good at predicting what lesions will eventually start progressing again. So to illustrate, usually if somebody presents with symptoms of leukodystrophy, those symptoms progress. But if you scan patients without symptoms, you often find these leukodystrophy lesions, but those leukodystrophy lesions can remain stable for many, many years. And of course, if you design a trial, you have to be aware of that not every lesion will automatically progress. So there's lots of data you need. This is because I'm sure people will talk on this in upcoming presentations. The leukodystrophy is quantified by the LUS score, something you hear many times. And the LUS score is basically a very simple scoring system. So you count what areas of the brain have an abnormal signal intensity, and then you score half or 1 point. And that leads to a score ranging from 0, so no ALD-related leukodystrophy, to 34, in which virtually all the white matter structures are affected. And as Eric Malek already showed yesterday, this score, it's still the most commonly used, but it's not that sensitive to small changes. He could show that while the LUS score can remain at 1 at several consecutive scans, if you, for instance, calculate a lesion volume, you can see that the LUS score 1 encompasses many volumes, that it can actually progress before the LUS score increases. So this is what we now use in trials, but it is not the best tool. So what would be better tools for this leukodystrophy? Well, like was mentioned yesterday, quantify the volume of the lesion, not just count anatomical structures. Neurofilament light is a blood marker for neuronal degeneration that is possibly useful in this sense, and functional testing like neuropsychological evaluation. So for trials for the spinal cord disease, maybe even more difficult because we have no imaging that really helps. Most people with pretty severe spinal cord disease, of ALD-related spinal cord disease, have completely normal MRI scans of the spinal cord, no signal abnormalities. So you need other tools. And what we use now is mainly functional tools. So how well can somebody walk? How fast? How many meters can you traverse in 6 minutes? And we know that even though those are definitely relevant measures, they're very imperfect because, again, they're not very sensitive. So for a very slow disease like ALD, your trials have to last for years and years and years, which is, of course, not very practical. And by definition, if your outcome is walking, then people who are already pretty severely affected cannot participate in your trial because you cannot measure change. Same thing for those that have no symptoms yet. They are basically at the ceiling, they perform normal at those functional tests and can also not be included in your trial. So you lose many people that could participate in a trial. So what there's new developments that are probably better to evaluate spinal cord function. And one tool that will be presented on this afternoon is body sway. And body sway is how much you wobble when you try to stand still. And that is highly sensitive for the function of the lung tracts in your spinal cord. So this is probably a better tool. And why is it probably a better tool? Because it is able to distinguish controls from patients that have no symptoms yet. So it's probably very sensitive. So the entire disease spectrum can participate. And what are newer developments? That the body sway used to be measured by this very bulky, incredibly heavy force plate that you had to haul around the hospital. But now that everybody has these nice smartwatches, there's these sensor systems that can also measure it, plus a lot of other parameters. And it is very likely that trials in the next couple of years will start use these as outcomes and produce results faster. Well, to make it even more complicated, what you select as an outcome measure probably also depends on disease severity. For instance, the 6-minute walk test that we discussed briefly is a very common outcome measure, still being used. But if you look at, for instance, this is the evolution of the 6-minute walk test over a period of 7 years in patients that were that were hardly affected. And you can see that over that period of time, there's hardly any relevant change. If, however, you start at the start of your observation period, somebody is already somewhat affected, you can see that it declines year upon year upon year. So if you would include many patients with few symptoms in your trial, you would measure nothing if you depend on the 6-minute walk test as an outcome. So that is also something that we have to be aware of when designing trials. So what do we have to work on? Better trials. It's not as exciting, of course, as working on new therapies, but very necessary, because now we're not great at doing trials, and that is, I think, really something should work on. Better measurement tools, better outcome measures, and also ideally ways to predict who will have a rapid progression of the disease and who will not, so you can select those most likely to benefit from your new treatments. And of course we do need new treatments because we have nothing really to stop the progression of the spinal cord disease that will eventually affect everybody. And of course, as you will hear, there's also a great need for better treatments for the leukodystrophy, either to prevent it or once it occurs to stabilize it. So hopefully, I think we're already doing a pretty good job in collaborating, helping each other. But for the really difficult questions, I think we need more data. And that's probably something we have to work on to better and more effectively share our data amongst centers. Yeah, and with this, I would like to end and move on to the presentations on the interesting new trials.
Thank you, Mark, very much.
Sure.
Are there any questions to Mark? Okay, then we can start the next presentation, please. So I will try to talk about the natural history of adulthood cerebral ALD. So, and what I mean also is progressive adulthood cerebral ALD. So how is this happening that somebody gets cerebral ALD and others not? So this is one of the secrets that we have not solved completely yet. However, I think that ALD is basically a neurometabolic disease which is causing neurodegeneration that starts at birth and ends with a death. So in between, there is a progression of neurological symptoms, progressive neurodegeneration. And for some reason, we don't know exactly, there may be some factors, maybe genetic factors, we call them modifying factors, or environmental factors, vascular factors. We don't know actually. Or is it oxidative stress? Somebody talking about stress, metabolic stress, chronic stress. Is this a factor to produce or the onset of cerebral ALD? I personally also am quite convinced that there are metabolic factors that are part of the reason why you get or had a higher risk for getting cerebral ALD. What I mean with metabolic factors is elevated long-chain fatty acids. I think there is not a perfect, but there is a connection between constantly highly elevated long-chain fatty acids and the onset or the risk of onset of cerebral disease. But this is only one factor to many others. Maybe head trauma will be another factor. You see a lot of patients who had a minor head trauma, and weeks after that they start with cerebral disease. So, but we fear, of course, that one of these factors may cause cerebral ALD either in childhood or in adulthood. So, progressive cerebral ALD, when it occurs, is lethal in most of the patients. Yeah. And it's of course, the progression is defined by clinical progression, onset of new symptoms, but also radiological progression. And we all know that this cerebral disease occurs in childhood in 30 to 40% of the males. Yeah, but we also know in the meantime that it can also occur frequently during adulthood. Yeah. So all in all, there is, in my eyes, there is a 2/3, 75% risk of getting cerebral disease over lifetime for all the males. So it's not nothing. That's substantial. So we have to take this into account. And second point I would make is the onset of cerebral disease is very, very important for any treatment interventions, for example, or treatment decisions. So we need to detect cerebral involvement as early as possible. And we can detect this cerebral involvement very easily by using regular MRIs. I know it's easy to say, but if you're not as a patient, as a male patient with ALD, if you're having AMN, if you're not on a regular MRI basis, you have your examination of the brain, then you have the risk to progress from a very minor changes in the brain to severe changes in the brain, which are untreatable anymore. This is treatable, this is untreatable. So we need to detect this one. Yeah. So this is an interesting slide. A lot of lines. What you see here in this graph is Leu scores. You already heard about Leu scores. Yeah? And ages. And these are information out of the literature. Maybe this part is out of the literature. These are children, ages 0 to 18. And these are adults. These are some from the literature, but it's mainly from Florian Eichler's center and our center. So what you see here is two things. You see first that the onset of a cerebral involvement is at all ages. There is no age without onset of cerebral disease. So it's not like you can have the cerebral disease in the childhood and then you're fine. No. And this is something frequently we need to recognize, or we have to recognize that people come and tell us we have been in childhood care as an ALD patient, and then we got 17, 18 years, and they say, oh, you can go away, everything's fine. It's not. Yeah? It can occur at all ages. And the second point is, you can see most of the patients, the LER score is steeply going up. So in most patients, once it occurs, there is a rapid progression of the disease. Not in all, as Mark already mentioned. In some, it's even stable, completely stable. We call this arrested, whatever that means. And in some, it is very slowly. I come to this point back in a minute. But in most patients, it's rapidly progressive, and it's lethally. So here's an example in the pH, and it can occur in two ways. This is the one way it may occur, like in childhood. It can start with a cognitive or cerebral disease. This man here is age 27, is a PhD student, was completely normal up to the age 27 when he detected some ataxia, some mild mood changes. And as you can see here, he already had at this point some severe involvement. And you can see it progresses over 2 years up to this stage where it's quite an end stage of the disease. Yeah, in 2 years. And he died soon after that. So other patients had AMN for many, many years. You see here the age 22, age 30, age 33. And you may have some corticospinal tract involvement, which is new degeneration, but then at some point over this long period, cerebral involvement may occur, and then you have a cerebral ALD. So these are the two ways how it can happen over time. And new data, it's a bit full here in this slide, but you can see that there are two different patients. The above patients started with involvement of cerebral involvement with age 40 and had severe deterioration and severe involvement 2.5 years later. And the other patient started with age 56, and it's 5 years later. It's not very much different. There's some progression, but very slowly progression. So obviously, some patients had a very slowly progression. And we did not recognize, or we recognized this for many years, but we did not understand it really. Maybe a new technique looking at the neurofilaments, which is a biomarker that gives you an idea how much the brain is degenerating or is involved with disease. And what you can see in these two patients, that this patient here, who is rapidly progressing, had this one here, I think, yeah. So he had a very steep increase of neurofilaments. And this patient with a very slow progression keeps stable with neurofilaments. It's elevated, but it's not very much elevated. It's not a steep elevation. So this biomarker probably maybe will help us to decide what is the progression rate in these patients. So maybe this is very helpful in the future. So the progression rates of MRI changes in children is this. This is all published data. And you see that over time, these are years, over time the LER scores are going up. And again, you see children who are rapidly progressing and children who are slowly progressing or even keep stable over a long time after having some brain involvement. So we call these arrested here, for example. So on the right-hand side, these are new data from adults. These are only adults. And as you can see, the steepness or the progression rate is completely the same. So this is not a different disease. It's the same disease in childhood on adulthood. And the progression rates are completely similar. And again, you have also in adulthood patients with very rapid progression, very steep lines going steep up, and others who are stable over many years. So this is another point to look at. And finally, this progression of Loewe scores, or progression of MRI changes, is very much correlating with clinical progression. You must understand all these, but these are clinical scores. This is a psychological score. So the MRI is relevant for the decision if a clinical progression is meaningful or a radiological progression is meaningful. So this is highly correlated between clinical and radiological scoring systems. So we can use this also for making decisions in future. And finally, of course, we want to know what is the outcome. And these are Kaplan-Meier curves. You already heard that. This is survival. Again, this is the comparison between the literature. These are children. And you see that there is a rapid decline in children. So every step down is somebody is dying from this disease. And if you look at the new data from the adults, it's completely the same. So again, this is not a different disease. Childhood disease and adulthood cerebral disease is the same. We have median survival rates of about 3 years. Yeah. Okay, in summary, I think there are potential risk factors, for example, head trauma or high very long chain fatty acids, that may influence the onset of cerebral progressing ALD. The onset may occur at all ages. Yeah. So it's very recommendable that you have an MRI on an annual basis. But finally, the real progression of an individual is hard to predict, even though that most patients progress very quickly, but there are also patients who keep stable or progress very slowly. But one thing is really clear: we need early treatments for this cerebral disease to stop the inflammation and to rescue life. So, thank you very much. Caroline is now talking about how to rescue the life of a cerebral ALD patient, hopefully. What do you think?
Yeah, I will try my best.
Okay.
Okay, hello. I'm glad to be here and to talk about the current treatment options. I'm also from Germany, from the Leipzig Leukodystrophy Center, so some things might be different between how we do it in Germany and in the US, but I hope still that there is some helpful information in the talk. So Wolfgang, these are my disclosures, of course, and Wolfgang just mentioned how also adult patients can be affected by cerebral adrenoleukodystrophy, and that's a disease course also in these adult patients, and about 90% of the patients is fatally progressive unless we do something early on during the disease to stop it. And I briefly want to mention what options we see at the moment to stop the cerebral disease. There's one treatment which is approved by the FDA and the EMA, which is the gene therapy, which is approved for children. It is only available in the US, even though it's approved by the EMA, and it is not approved for the treatment of adult patients. We do have quite a lot of experience by now with the hematopoietic stem cell transplant in children and also in adults, and this is what I want to talk about briefly in the next minutes. And we, in addition, do have ongoing studies for new compounds which we also try to cure or to stop the progression in CALD. So this is what I think how the disease could develop. I think it's controversial still, but what I conclude from histopathology and what I learned so far is that there might be an early damage to the immune cells of the CNS, which is the microglia cells, and alongside, or maybe even secondary, we have an extensive damage of the white matter tissue. And I think the inflammation that we see on the MRI in the patients is something that is kind of secondary to this and is to remove all this damaged tissue. And I think this might also be an explanation why the immunosuppression treatments that have been tried before are not so effective, because in the end we have destroyed tissue that is removed. I think there are other possibilities and other possible hypotheses about how this could work. But if we think this is what happened, the way that hematopoietic stem cell transplant would work is that we can, by conditioning the patient, we can get rid of the blood system of the patient. We can transplant healthy donor cells into the patient, and cells from monocytic myeloid cells from the donor will leave the vasculature and will engraft, hopefully, the brain and replace these defective cells, and thereby prohibit that there's a damage to the brain tissue. In Leipzig, we have treated, or not only in Leipzig, but in Berlin and Leipzig from 2006 to 2023, we have treated 24 patients, adult patients with cerebral ALD with hematopoietic stem cell transplant. This is over the years how many patients have been treated. We had unfortunately 7 deaths among these patients, but we now looked recently again at the long-term outcome of these patients, and we see quite a good stabilization of the disease in most of these patients. So this is one of the patients that we followed up for 10 years, and again you look at these white spots here in the cerebrum, and you see that right at transplant time compared to 10 years after, there's only very minimal progression of these lesions. So this patient has been stabilized by the transplant. So it would not move. Oh, sorry. So this is the survival curve again. And what you learn from this is that the early time is the critical, so most deaths occurred in the first 2 years after transplant, and the patient who survived more than 2 years, they are stable. Last week only we had a patient dying, but this was of lung cancer, unfortunately, but most of these patients are alive and are following still coming to our center for follow-ups. From the 24 patients that have been transplanted, 7 died, so we have a survival of 71%. We have lost, or we don't have information for 2 of them why they died. 3 of the patients had transplant-associated death, and 2 patients were not stabilized and progressed with CALD. We have some patients who had graft-versus-host diseases, but most of the patients are now off long-term immunosuppressions, only 1 who's still taking medication. And this is a similar study that was initiated by Jörn Kühl, who is a child hematologist in Leipzig. And it's very interesting. So he had transplanted patients in childhood, and he recruited patients for whom he checked that the transplant was more than 10 years ago, and they had reached adulthood, and he brought them back to our center now for assessments. And most of them had not followed up anyhow, so they have not had any regular assessments for a long time, which was kind of the first insight of this study. And what Jörn found was very similar to what we described. So he had a group of patients that stabilized within the first 2 years after transplant, and these were doing quite well. So we have also done neuropsychological assessments and so on, so they are really doing fine. And then there were some patients that did not stabilize within these first 2 years, and these were the ones that did also not do so well in the long run. So there were 2 more deaths after 14 and 18 years, and they even also sometimes progressed even further after the transplant. One case was particularly interesting to us. This is one boy which has been transplanted in 2000. He had a good engraftment rate, we call it. So this is a measure of how many percentage of your blood cells are derived from the donor and how many are your own. So this patient had, right after the transplant, had 100% of the cells from the donor. And the cerebral disease had arrested after the transplant. He went to follow-ups for some years. The last follow-up was in 2009, and there it was documented that only 34% of the blood cells were from the donor. So he has lost what we call chimerism. So he has lost a lot of the donor cells. And then when he came back for this study in 2023, we found that the chimerism even dropped more. So only about 1% of his blood cells was still from the donor. And when we looked at the MRI, we even saw that this is very tiny and maybe not so good to perceive, but if you look at this structure here, we call it anterior commissure. It's a connection between the 2 hemispheres in the front of the brain. And this has been quite darkish here, but if we look now, this is a white alteration of the tissue. You can also see it here, that there's this white spot. And we even have, and this is maybe hard to perceive, we have a little bit of contrast enhancement in this patient. So it seems that he has lost the donor cells, and he also kind of reactivated the disease. And for us, this is kind of a very important finding, because often there is this question, how should we follow up the transplanted patients? Are they cured? Do we need to see them again regularly? And I think this is kind of a lesson learned, that that it makes sense to go to follow up also after transplant and to check these patients and to follow them. And with this, I already want to summarize. So we see in the adult patients that the transplant can be effective. We see long-term stability in most of the cases that reached stabilization within the first 2 years after transplant. And we think that screening anyhow before you have CALD, but also after you have been transplanted is very important in the patients, and yeah, that you should go on with it. I think the other options that I mentioned, like gene therapy and also leriglitazone, there will be separate talks, like more information about stem cell transplant, so I will not go more into detail.
Yeah, thank you very much. Questions? Yeah. Wait a minute.
It's kind of corny, but after a head trauma, what would you suggest somebody do?
You cannot change your head trauma, so you already have it. So you just wait and see.
It's a wait and see.
Yeah.
You shouldn't, ice or anything, or try to slow the...
Ice would be a good idea if it's a boiler.
Yeah, I think for us, at least for the adult patients, we would not screen them earlier, like regularly.
Yeah,
I mean, if it's a very severe trauma, maybe you can think of it, but I don't know. I think in general, I mean, my feeling is there are lots of head trauma in the daily life, so it's always difficult to really follow up all of them, I think.
Yeah, I got it.
Yeah, well, I must say, this is these are reports, individual reports. There are some reports in the literature, but it's not systematically reviewed. So that's one thing we need, for example, a big registry for, what Mark already proposed, that we should have this to answer these questions.
Okay.
Yeah. Another question.
I never could understand why most AMN guys are bald. And is it a shortage of something, or has anybody done a study?
Yeah.
It just doesn't make sense.
I did a study.
You did a study?
Yeah, I did a study in that with the dermatology department. So it's a doctoral thesis about this. And she noticed that the bulbs of the hair bulbs, are somehow infiltrated by long-chain fatty acids. So there's changes in the tissue, which also causes a premature what's it called? Aging, premature aging of the hairs.
Okay.
So that's what her conclusion, at least.
So why?
It's okay.
Yeah, I mean, I'm the only. They always said I was faking it.
No, you're not faking what. So there's a question from online. Can one access gene therapy if they have non-cerebral AMN?
No.
No.
But there will be another talk about it, I think.
Yeah. So I think it's not for AMN. It's gene therapy, not yet.
Are you still performing the allogenic stem cell transplants for the men with cerebral ALD? And do you know about how many you've done since the last study that you've tallied up here?
So in Europe we don't have the option of gene therapy for the transplant. So we are only doing this allogenic, and it's also in the adults. We only do it.
Oh, you were asking for gene therapy?
No, I just misspoke. I meant
the stem cell therapy.
HSCT.
Yeah.
Sorry.
So
you're still doing those. Do you have any idea how many you have done or are in process about to be done since you tallied up to get all this data that's up there?
I think, we have patients with cerebral disease, which right last week or so, which we will screen and evaluate. We will also have now the option, or we always think about also treating with leriglitazone in the upcoming study. But there are continuously patients which we would evaluate. And as you saw, there are some years where we had 4 and some years where we did not have any patients. So it's always hard to predict, but there's no change in how we would select patients or how we would treat them.
You have to almost look back over a period of years to get enough data like that.
Yeah.
Okay.
And work together with other centers probably.
Yeah. But the good news is that what Caroline is telling us, that once you have taken the risk of the first 2 years after transplant, all survivors do really good, which is in strong contrast to the natural history that I showed you before. In strong contrast.
Maybe 3.
Yeah. You have a question? Last question? No.
I do.
Oh, there's another question. Oh. Okay. So somebody asking online, is it because the mortality rate is too high? Oh, so it's still referring on gene therapy in cerebral AMN. Wow. What is that cerebral AMN? Well, the question is a bit difficult to answer. So we don't have stem cell therapy in AMN. We don't do that because the risk of this treatment is much higher than the progression, the slow, usually acceptable progression in AMN. So there are other treatments necessary for AMN only. So, but for cerebral ALD in adulthood, as in childhood, we always look if this is a patient who's able to be is being able to be transplanted. So these are at least early patients. And very late progressing patients, it doesn't make sense to have them on the stem cell treatment. But I think Troy will tell us more about this in a minute. So
There
I'm
was
happy
one more
to.
question, I think. There was one more.
One more question?
Actually, that answered it. I was
Okay.
Okay, it answered. Okay. So I now can welcome Troy Lund from Minnesota. He will tell us more about the chances and risk of the stem cell therapy. So.
Okay, great. So I just put together a very brief number of slides, like a dozen slides. I wasn't sure how much time I would have just to talk about some of the risks and lay them out there. Here's my disclosures. So what does a patient need to know going into a transplant center? So often I get asked, what should I ask about if I'm a patient? And I guess the first thing you should ask is, what is the expertise in that center? How many transplants they've done for ALD? How many transplants for adults with ALD? Those are two big questions I didn't put up here, but those are the first two questions I usually come up with. But then you can get into the nitty-gritty of the type of transplant, and you can ask about the stem cell source, for example. Is it a center that just does peripheral blood? Will the center do a cord blood transplant? Because not many do, actually. And if you use peripheral blood, you're at a higher risk of graft versus host disease. So, like, we prefer bone marrow if we can get it. I think those are all important questions to ask. The type of conditioning, is the center going to use what we call myeloablative or ablative conditioning, which is more chemotherapy, or are they going to use what they call a reduced intensity conditioning regimen, otherwise known as a RIC, to try to get away with less chemotherapy? Less chemotherapy is better on the body, but it's not so good for this class of diseases because you don't engraft your brain if you get reduced intensity chemotherapy, and I don't think it's as effective in treating adult cerebral ALD. But it's an important question to know, because otherwise, if you don't ask, you're not going to know. I did put, I guess, center experience up there. What is the follow-up schedule? A lot of times I'm asked, like, what are the nuts and bolts of going there and living there? For us, we have a workup week for a patient, so it's about 4 or 5 days of x-rays, a CT, examination of the heart, kidneys, make sure everything's in good shape. And then the patient comes back about 4 weeks later, and then they get admitted to the hospital. They have about a week of chemotherapy in the hospital. And then there's about 4 weeks of recovery in the hospital until your body accepts the graft and you can get out of the hospital. And then there's about 2 months within the Minneapolis-St. Paul area. So that whole thing is about 3.5, 4 months, and that's without any complications before we send you back to your home city. And that's a pretty standard regimen, so it gives people an idea what kind of time commitment they're looking at. And we always like to have a caregiver with the patient. And so for the kids that I transplant, there's generally always parents, and parents take care of their kids, or at least they're supposed to. But for adults, it's different. And transplant is tough. It involves chemo. There's a few medications for anti-rejection afterwards that you get on. We try to get you off of those within 6 months after transplant. But keeping track of all the medicines is hard, so we always almost insist that there's some adult caregiver around to help the patient. And that leads to a better outcome, because it's hard to do it by yourself, if even possible. And then, of course, the last thing is, what are the risks of transplant? So every center has their own table of risks, and they should be able to give you a number. So that's always an important question. It kind of goes along with the experience. If you've done a bunch of adults with cerebral disease, if you've done 6 and they've all died, well, it's 100% mortality, which is not great. But it's important to get that number. I think everybody should know that. And then there are more generic risks, like people are going to be sick during chemo. There's going to be a risk of infection within the first 3 months of transplant. That can be from bacteria, it can be a common cold virus, it could be from a fungus. That's important to know. There's the risk of organ toxicity from the chemo, like to your liver and your lungs, so also important to know. There are, of course, the risk of graft versus host disease in an allogeneic setting, and that risk is center specific. So every center has their own GVH risk table, and that depends on how you do the transplant. And a lot of people don't realize that, but that's how it kind of works. And then long-term risks, of course, from chemotherapy. What is the sterility rate? Because these are chemotherapy drugs. What is the secondary cancer rate? That's usually a skin cancer. So those are all the things that I think people should be asking about. And there's probably a lot more that I left off. I was just trying to think of the kind of the big questions I get all the time, from the nuts and bolts is how long is this going to take? I guess the other one is, how do you do the transplant? How does the surgery work? So yeah, that's a big one. It's not a surgery. The transplant is in a bag, essentially, and the bag gets hung next to the bed, and there's a tube to the IV, and a transplant just goes through an IV into the arm. Basically, that's how you do the transplant. So, and those cells enter the body, and they magically know where to go and what to do. We actually don't understand how it works, but it's not a surgery. It's really just, it takes about 30 minutes for that bag to go in, and then it's pretty uneventful, pretty boring. So I think those are the big questions I get. What else? So what are the risks? So more details, like how does one assess risk? How do families do it, or how do I do it? You can read. I mean, we all publish our outcomes in journals, and we're constantly updating the data. You just saw some new unpublished data from the German group, so you can read and go to seminars and understand what the risks are. You could guess, like that's valid. You could just say, I don't know, it's 50-50. So hopefully you don't have to guess. I mean, I think there's enough data and literature that we don't have to guess at most of these risks. You can extrapolate, which is a big one. So I could extrapolate the risks for an adult having a complication based kind of on what I see in children, because we've done 300 transplants for children with ALD, and we can extrapolate from their risks what an adult might experience. You could also extrapolate from adults with other diseases. So there are a few other adult diseases, adult leukodystrophies that we transplant, like metachromatic leukodystrophy and ALSP, for example. And I suppose even adults with leukemia, lymphoma, who are getting the same chemotherapy that an adult with ALD might get, you can extrapolate from those risk tables as well. So what I did is insert this excellent data from the German group. They really have their act together and are very organized and are able to publish. This is the pediatric data that we published. Next, I'll show you the German data. But these are the children, and these are survival curves. So A here is the bottom is years, 0 to 8 years, and this is the groups broken down by less score. And so if your less score is less than 10, your survival's almost 100%. It's like 90-some%. If you're higher risk, greater than 10 for your less score, it drops down to about 70 to 80%. This data is a bit older now. We actually need to update it because the curves are actually better. You can stratify by how many symptoms you have. If you have no symptoms, again, your survival is about 90% or higher for the child. If you have symptoms or more than one symptoms, it drops down. You can stratify by related and unrelated donor. These curves have actually now come together as this data is a bit old. And in this interesting piece of literature, we actually looked at kids that were on N-acetylcysteine and those not on N-acetylcysteine, just to see if there was any effect. It turns out that those on N-acetylcysteine and high risk had excellent survival. Though if you were high risk and not taking it, you had inferior survival. So it's some indirect evidence that N-acetylcysteine is playing some biological role. So we employ that now as standard of care in our protocol. All right, so yeah, here's this excellent data from the German group who, yeah, you just saw some of this. The overall survival for adults N of 15 at this time was almost 80%, which is really good for adult diseases. And you can again stratify patients according to no or mild symptoms, which they did here, and they had 100% survival. Though if you had moderate or severe cerebral symptoms, much reduced survival down to 50%. So what that tells you is that an adult that has some symptoms and is more advanced is not going to do as well through transplant versus somebody who gets the transplant with hardly any symptoms whatsoever. And this is also another interesting piece of biology is that if there was internal capsule involvement, which is part of your brain, if you had no internal capsule involvement, you had excellent survival. Though if you had internal capsule involvement, so if this part of your brain was involved with ALD, you had very poor survival. Something we don't quite understand, but for patients that are less mobile, they don't seem to do as well through transplant. And there might be an infection risk or some other phenomenon playing a role. So I was interested in this at the time, so I actually laid out the internal capsule. I found a nice picture of it, because for me, I like to have pictures. So it's this fibrous band of nerve tissue going all the way down to the brain stem and all the way up. And this is kind of what it does. These nerve tissues nerve tracts are involved in motor control and vision and hearing. Some tracts involved with mood, memory, cognitive function. And in fact, in this website, they talk about small lesions to this structure results in major functional deficits. So you can't move your limbs, you may have loss of touch, loss of motor control, and even cognitive memory defects. So it's a very important structure. And you can actually see it on MRI. It's right in this cross section, it's right here. It has a posterior limb, D, has this curve in it, it has the anterior limb just up here. So that's what we're talking about. And again, if you're at a transplant center or you're a neurologist, you can look at these images and you can ask questions like, do I have internal capsule involvement? What does that look like? What does that mean for me? I go through the images with all my patients, whether they want to see them or not. And so this is what an adult, this is what a patient with internal capsule looks like. So they have involvement right here through the internal capsule. And again, that portends not as good an outcome as somebody who does not have that, for reasons that maybe the neurologists understand better than me, why it's such a critical structure. But we actually see this in kids too. If they have that involvement, the kids don't do as well either. So then risks and benefits is all about a scale in my mind, of course. It's a common way to kind of weigh things. It seems to be a lot of risks here, but I just was trying to put it together quickly. What are the risks? Well, I talked about chemotherapy and chemotoxicity, and that's kind of the effect on the organs like the heart, the lungs, the livers. Talked about infection. Again, that infection risk is greatest in the first 3 months after transplant before it goes down, just because you don't have an immune system, or the new immune system is just starting to develop. You can progress through transplant, and that's partly due to the chemotherapy and its effect on neurons that are weak or damaged or dying. So you can have a little bit of progression before you stabilize. Always the risk of graft versus host disease when you're using somebody else's cells. So unless you're using your own cells, there's always some risk of GVHD. The transplant can fail, like the engraft can go away. We don't understand why that is, but every so often a transplant just won't take. And that's bad for diseases like this, because oftentimes there's progression. You might have to move to a second transplant, which takes on a lot more risk. And of course, there's a mortality risk. There's a risk of dying through the process, and that depends on where you're at. Of course, what are the benefits? Really, the goal is to slow or halt disease progression. Slow it down so you end up with a much longer life. So the other benefit then is life extension versus the natural history of not being treated. And then with the longer life, I always stress quality life. So what is that going to look like on the other side of transplant? Are you going to be mobile? Are you going to be independent? Are you going to have any dementia, for example? How much worse are things going to be? And you can get hints of how to predict that by looking at the MRIs coming in and the clinical status of the patient. So why do we have these risks for adults? Why does it seem adults have more risks, basically? Often the adults come in later. So they seem to show up to me more advanced. The brain is more involved. There's a higher LES score. They've either not gotten MRIs, or they've been presenting late, or they were diagnosed late. Age by itself is a risk factor. So if you're 50, you do better if you're 70. If you're 30, you do better than if you're 50. And if you're 20, you do much better. Age is really complicated, so I'm not going to go into the details of why that is, but age is a factor. So younger people do better. I talked about the internal capsule and the immobility. And we've seen this, and our German colleagues have seen as well. Patients that are not as mobile don't seem to do as well. And that might be related to infections, specifically urinary tract infections leading to sepsis. But it's a bit speculative, but we kind of noticed that in some of our patients. Adults are less chemotolerant. So you can give a child all sorts of chemotherapy, and they do pretty well with it. Once you get older, I'd say past age about 26, the body just doesn't handle it as well, it seems, for reasons we don't quite understand, or perhaps the liver enzymes that process the chemo are different in adults, but they just have a little bit harder time with it, so important to know. This is some of our MRIs. So, and then finally, how do you reduce the risks? How do you bring these risks down as low as possible to have a good outcome? Transplant as early as possible in the disease. So as soon as there are MRI changes, we do like to see a gadolinium enhancing type of MRI lesion. So as early as you can in the disease will portend a better outcome. So that is, be identified earlier in the disease process and not later. And then stay healthy. It's very, it's a simple thing to say, but people that have a decent diet, decent exercise, reducing your infectious disease exposure, living healthy. Adults tend to pick up bad habits. Either they drink a lot, excessive amounts, they smoke a lot. Like those two things don't set you up for a good transplant outcome, or they may have other unhealthy behaviors. Obesity is a big one too, high-fat diet. Those aren't healthy going into transplant. So those are kind of the simple things to say, but it does require some life modification. I think that's all. Thanks.
Yeah, thank you, Troy, for this wonderful talk. Are there questions to Troy? There's one question from the online. Let me go back there. So, when you have a moment, could you touch again on how you are using NHC and NAC, and when and what benefits you are seeing? NAC.
NAC, and it's a fantastic, potent antioxidant. In the lab, it does really amazing things to cells. It seems to restore the cellular health. It takes away oxidative stress. Cells become more viable. But that's just lab tricks. But the data I showed you in the people can't be, it's hard to argue against the survival advantage. Even if I don't exactly know what's going on in the person, there seems to be some survival benefit for those that are on N-acetylcysteine. So it's probably improving brain health somehow. The dose is 70 milligrams per kilo every 6 hours for 28 days. If you're high risk, it's 400 days. So that's how you use it.
That's a question.
This is a
follow-up question to that, Troy. I know Aurora Pujol has some research from a few years ago about NAC preventatively, right? So are you giving it to patients prior to transplant as standard of care, or is this only with transplant?
Oh yeah, I've probably given it to 30 patients prior to transplant. I mean, it doesn't do anything to the disease itself pre-transplant. Like, it doesn't make gadolinium lesions go away. It doesn't change kind of progression, because we've tried that. But during transplant, it definitely modifies certain aspects of the disease I don't quite fully understand, but it's not like a cure or anything like that.
Troy, there's another online question for you. It is one of the components. No. Yeah, it's one of the components of the comprehensive protocol I have researched and developed. Who's saying that? Patrick, to everybody. Patrick?
Okay.
Obu?
I assume so.
Hi, Patrick.
Hello,
Is that
Hello,
you?
can you hear me if I chime in here?
Oh, yeah.
Are you able to hear me?
Yeah, we hear you.
Oh, wonderful. Yeah. So, I mean, just a side note, I mean, I'm a holistic nutritionist, so I've just been researching different components for a protocol. And some of them are based on some of the studies that were done in France and Spain, that high dose antioxidant protocol, and TUDCA. So, I mean, I'm trying it. I mean, I'm seeing some benefits. I have AMN. I don't know for sure, but I think it's worth a try.
Yeah, I think for a lot of families that I can't take to transplant, I agree with antioxidants and a healthy lifestyle. A lot of the antioxidants are vitamins, and I agree with taking them. Generally, they're non-toxic. It's hard to overdose on some of those things, but taking them within a reasonable moderation, I don't think is going to hurt, and there may be benefits to them. So yeah. I'm fully supportive.
Yeah, it's hard to know. I mean, I'm 42. I don't have cerebral. I mean, I've progressed, but I mean, hey, right?
Yeah. No, good job.
Yeah.
Okay, thank you very much. So, just to summarize this part of the discussions we had, I think it comes out clear that there is a way to stop the progression of cerebral ALD, but you have to do that as early as possible, and you have to take a lot of risks with that. And of course, it's an obvious question: are there other possibilities with lower risks? And probably Patty will give us some enlightenments in this respect. I can also. It didn't work previously. It didn't work previously at this line there with my computer. Why don't you? It is good. It is. It's good. Okay.
One second, I'll be sharing this.
That's Patty. She usually needs to finish her talks 5 minutes before.
Like I'm doing right now, guys.
Yeah.
I gotta apologize. We're just filing right now the orphan designation to the FDA for another very needed leukodystrophy treatment. So it's a pleasure to be here always.
No, not yet. Here.
I don't have a microphone. Oh, I have to get it. There you go. Hello.
And I can announce after Patty's talk, we will have a short break for bio break and some coffee.
Hello? You. There you go. Alrighty, so always a pleasure to be here. This is not the right title slide. Let's move on. So I wanted to present everything we have learned in the last pretty good 10 years almost of using liraglutide in patients with ALD. So we have been, so there are several studies. There is a small company called Minorex based in Barcelona that found this molecule may be a good anti-inflammatory
maybe helping with myelination, did a lot of studies in mice with all the collaborators in ALD that they could find, to the point that when we go to the regulatory agencies, the FDA, there is no one without a conflict of interest to show up. And that's what's happening now. We don't have experts. But again, reiterating, so I'm going to focus on cerebral ALD. And I want to tell you what we learned about later glutathione effects in cerebral ALD and how that compares to everything you just heard, bone marrow transplant, allogenic, related, and how does it compare to gene therapy? Very briefly, I'm not going to go into the others because we have presentations that are going to cover that. But one of the things that is important is to always remember that these two neurological phenotypes, don't forget adrenal insufficiency. It's very important. It has a treatment. It's lethal. So we need to be monitored and treated for adrenal insufficiency. But talking about, and that's the adrenal gland on top of the kidney, and your cortisol levels. But talking about the brain and the spinal cord, there are two, we call it phenotypes, which are the way patients suffer from the disease. That's what phenotypes means. And one is affecting the brain itself, up in the head. And the other one is affecting the spinal cord and the nerves that go into the body. And that's what we call spinal cord, and neuropathy, peripheral nerve. So an adrenal carries around because of the adrenal gland. That's why we call adrenoleukodystrophy. And this one, you guys know very well. I'm not going to talk about glutathione effects on AMN. I'm going to very briefly brush through it. And then I'm going to really concentrate on what is cerebral ALD. And I kind of put here some very simple definitions, but myelin, which is the white matter, the connection between the nerve cells across the brain, is in this area that is here in black, in this MRI of the brain. And what is white is the lesion. So that is where we see the myelin, the connections, being degenerated. And we know that there is a component of inflammation in that degeneration in the white matter. And everything we're doing in the treatments is trying to control that immune system attacked to the brain. So there are different treatments that we know that have been tried in ALD. In fact, we're putting a review for the people to know there's a lot of drugs that have been tried in children primarily with cerebral ALD. And many of them haven't shown enough effect to really justify changing the practice that we have right now. And then when progressive, the cerebral lesions that appear in the brain, the growth is very stereotypic and rapid, and it does cause neurological function loss. Not to underestimate that AMN is underneath and is going to degenerate very slowly, very different. There is almost no inflammation in AMN, okay? So there are kind of different types of diseases. So this one doesn't advance, so good that I have my computer here. So this is a slide that Florian Eichler has put together, and it's a very simple one. I love it. So these are the three things that patients with ALD and the ABCD1 deficiency in the genetics can suffer from. And you can see adrenal insufficiency in green. It's almost like it's going to happen. Like you just live long enough at some point, being a male, so a boy or a man, that will be the risk of having loss of cortisol function, adrenal gland function. And then cerebral ALD, we know there are 2 times in life that are high risk to start the disease. And one of them is kind of childhood, and we always say like anywhere from 4 to 9 is the peak of that curve, where most boys present with the disease. And then we are kind of, this is changing, but we basically seeing that almost every decade in adulthood has some risk of cerebral ALD. And we call that conversion, meaning you have AMN developing in the background very slowly, and then at some point you may get also cerebral ALD on top of your AMN. So having a diagnosis of AMN doesn't take away that you may develop the inflammation in the brain and have cerebral ALD. And this is just to show that the MRI is really correlated to what we see when we do look at the brain in the pathology, and we do see loss of myelin. Myelin is in this picture will be blue. And you can see how little blue is left in this particular part of the brain that was affected by the disease. So let me get this closer. So basically, this is something that we are kind of even changing definitions now that we are starting to have treatment. Because it's important to know who can we treat, when can we treat them, and what are we expecting them to do if we treat them. And one thing is to have no lesion. So I put a very plain clean here, MRI without anything, you can see these areas called the corpus callosum. That's where 80% of the lesions of ALD start. You can see cerebral lesions, so the lesion appearing in this T2 image. And then what we call progressive cerebral ALD, the lesions start growing. And you heard Dr. Kohler and Carolyn and Mark probably talking about some patients really sit for a really long time on this like steady, stable, we call it arrested if it's more than 6 months, but don't take that for granted. The arrested is maybe not arrested, but for sure, there are a lot of patients that have stable lesions. Does that happen in boys, little boys, less than 12 years of age? Less than 7% of them will stay like that, according to what we know so far. So if you're a boy and you're young, this is not your rule. Your rule is to move that lesion. That's why we're so desperate to get the boys scanned every 6 months. And the adults, we do have a different screening of scanning for the brain. We do it every year. And this is based basically on the lesions progress probably differently at the beginning of when the lesions appear. So this is another way to see it. One is born without the function of ABCD1, so ABCD1 gene defect. The brain is normal. The kid developed normally. Again, I'm talking about males here, not females. There is also not cerebral ALD in females. That's a very specific condition I'm not going to talk about. and it doesn't happen. You get AMN if you're a female, and other female ALD phenotypes that we don't yet understand, like maybe movement disorders and other things, like restless leg syndrome, which is part of that. But basically for the males here, at some point, and very commonly, 40% of the males with this condition will have a lesion in childhood. That lesion will go on to grow. And we also know something. When you see in this other sequence of the MRI, not the one that gives you the white patch, but the one that sees the contrast you put in the brain bleaching into the brain, which is called T1 post-contrast. If you see contrast enhancement, that's when we know the disease is picking up speed and is going to progress more rapidly, and those lesions tend to grow much, much faster, and that's what also leads to much faster neurological decline and loss. And many of these boys, if not treated, die. So this is our window for treatment, and I want to mention something. There is almost no symptoms in majority of the patients with these lesions. So the only way to go for the best treatment you can get and the best results to the treatment is to be on a scanning MRI every 6 months. Probably everybody in the room knows it, but if this is going to be recorded and put online, that's important. We don't wait for symptoms to get indication for transplant. And we use different markers of lesion and disease burden. There is something called the Lowe's score, and you can see it here, 0, 2, 4, 4 with Gatto, and then it jumps to 19th. That's what a 19th looked like. Volume, which is the amount of myelin brain that is being affected, that's very important. And then we have some markers of how the brain, when it's degenerating, can show up in the plasma, neurofilament light chain. And then we have clinical markers, the neurological function score, developed by Kennedy Krieger many years ago, specific for ALD, and the major functional disabilities, which are some of the domains of that scale, which are much more severely affected, like seeing, talking, walking, being able to feed by yourself, and continence of bowel and urine. So again, I'm going to hammer these terms because I want to show you the results of a drug that is not a cell therapy or a gene therapy. So it's a small molecule, and we're going to see an effect that is different than if you're doing a biological therapy. So non-enhancing lesions, and then we think a lot of patients, the majority in fact, will progress at some point to rapidly progressive or progressive lesions. And then we know that that MRI correlates with neurological decline. I'm gonna, I don't know if I think I can play this video. And this is one of our patients in Boston. And I'm not gonna use the video, I'm gonna use the images. So this kid is 7 years of age, didn't know the disease was in the family. This is before newborn screening in Massachusetts. And was in his karate practice, completely neurologically intact, developing normally in school. I'm guessing we didn't have an MRI because he wasn't in screening. His MRI lesion was probably this size because only 8 months later, he's cortically blind, unable to walk independently, cannot feed. And this is what ALD does. And today, and the majority of my patients, I speak Spanish, come from Latin America, follow more than 700 patients in the entire Latin America with ALD. That's still the natural history. There is no newborn screening. There won't be newborn screening for many, many, many years. Not to say that in Europe there is also not newborn screening that we should have, and there's efforts going on to try to install that. But this is what a lesion that causes this level of neurological disability tends to look like, and that's one just keeping consistent the scans. They're not the same patient, but just for the sake of trying to transmit and communicate what MRI and clinical correlation can look like. So again, we know we have a genetic defect. There is very long-chain fatty acids that can diagnose the patients, mostly if you're a boy. You get a lesion. The lesion gets inflammation, contrast enhancement. You go rapidly. So we try to treat in this window, and this is what Dr. Troy Lunt was presenting just a moment ago, which is the standard of care, which is a transplant, and then try to get cells of the immune system be corrected to have the expression of ABCD1. I want to point out that these lesions don't stop all of a sudden when you graft it. It takes some months to really halt completely the development of that lesion. That's another reason to go early. As smaller this lesion is, I'm going to say this a couple times, the smaller this lesion is when you're getting transplanted, the better the outcome. Okay, so to the point, and this is Dr. Lunt's work in Minnesota with neuropsychological testing and very refined data, and Dr. Köhler for the adults in Leipzig. If you're able to transplant a patient with a LOS less than 4, you have the best cognitive outcome. In fact, if you give them a choice, LOS less than 3. Okay, 4 is the one that is on the edge, so it's less than 4, not 4. So 1, 2, 3 is when you want to be transplanting. That means completely asymptomatic boy. And that's it. To me, that's the objective for all my patients that take 8 months to get to a transplant or a year. I want them all on a LOS of 1, 2, 3. So give me anything, even if it doesn't cure ALD or cerebral ALD, that keeps the lesions smaller, I'll take it. Because they need to get to the treatment that can stop the disease and rescue the life of these people. How does the transplant work? We really don't know, and I did extensive research on this and everything. We know, we publish it, and there's more coming, I think. But basically, we think the cells that we corrected are coming from the bloodstream. They're going to get to the brain, and they're going to change some of those that are affected by the gene mutation, replace them, and stop chewing up the myelin, which is that thing that insulates the nerve axons. So this I was kind of talking about here. These are easy to see, okay? This is what we are seeing with newborn screening now. And we also published this with Dr. Malak and Liberato. This, by the way, is all work mentored by Dr. Eichler. So if you wonder, where do I come from? So that's where I come from. I really been working with him since 2005. But these are really hard to see, and that's what we are learning the disease starts like. And you can go retrospectively and see these lesions in retrospect are very hard to sometimes get to diagnosis. But time passes, but still these lesions, if you look at the size, they're more than doubling in size. And if you look at the sphere that this lesion is in 3D, they're growing exponentially, okay? They're growing really fast. So, and we need to understand this a lot better. I'm not gonna underestimate how little data we have, but newborn screening is now getting standardized in the US. We'll have this data. It's gonna take us a few years, but we'll learn what these early lesions look like and what is the progression, and we'll be able to really judge what is effect of a drug or not. What about that contrast enhancement, gadolinium positive lesions, and whether or not that's the thing that we need to follow? Remember that you don't go to transplant most of the time if your lesions are also not enhancing with gadolinium contrast enhancement. So inflammation needs to be there. This is an schematic of a vessel in the brain, a cell that is flowing in the bloodstream, and is trying to get access to the brain. This is a very complex process. But when a cell is transferring, there is also the gadolinium can go through. It's much smaller than a cell, by the way. It's probably this size. So there is the possibility of having gadolinium enhancement with or without inflammatory cells there. But that basically is something we know precedes a long way. This is the lesion. I cannot even see it. This is contrast enhancement in a very sensitive sequence, which is called perfusion imaging. And that's the first incipient of a lesion in the T2. And there is still not even a T1 post-contrast. So that smoldering inflammation is there even at the very beginning of these lesion formations. So Yeda, when you get us therapies, just please, we want this to go away. If we can stop that, you don't get a lesion. So hopefully that's, and this is 12 months in this patient before we see T1 contrast enhancing lesions. So also the importance of developing new techniques to diagnose and have better biomarkers of the disease. So natural history of progressive cerebral ALD. So not patients that are arrested, but those that have lesions that grow. And this is what we know in children. This is what we know in adults now. Thank you to the work that Wolfgang has been leading. This is what Wolfgang was showing you before. Like, when it takes and it starts growing, they all kind of behave the same, regardless of age. So cerebral ALD, bad disease, act now. If you had to put it on a slogan. That's a message for all to have. Not because I'm older, I'm fine. Just please get to a center of expertise that can assess that lesion, continue following, and determine what treatments are available to you. And this is putting it all together. I think we were showing this. This is the adult population. This is the children population. And this is that score that we were talking about, the 1 to 34 score, the dose score. And that's these curves of how these lesions tend to grow, kind of average here in this blue line. And as you know, bone marrow transplant, and I just heard about it, so you get cells from a donor that has the gene, has different side effects if you're having a donor that is not related to you. So allogeneic stem cell transplant, you have to go to myeloablative chemotherapy, go to hospitalization, you stay in the hospital for a long period of time. You heard Troy saying what the burden is for the families. You really need to set up your life in a center for supporting that child or that adult. And still, for some reason that we are not really sure, the side effects on ALD, and I will say Minnesota probably has the best profile of side effects that are not that high, but the ones published across the world still shows that it's not exactly as manageable as it is for other bone marrow transplant indications, like leukemias, okay? So these patients have higher rates of complications. And of course, if you have a related donor, you do better. And there's a bunch of limitations on how to find a donor. I take this slide from Kristen Duncan, and this is if you're white. These are your chances of finding a donor in a bank, okay, bone marrow bank. This is if you're Hispanic, this is if you're black, and this is if you're Asian. And if you're from Latin America, which means these three together, your chances are less than 20%. So are we done with treating ALD? No. And again, this is a call out to everybody that is racially different. Please get your whole neighborhood to donate bone marrow, because then you'll have a donor. That's another way. It has a solution, but it requires a really big effort. This is the gene therapy. So in the gene therapy, instead of having a donor, you take the same kid's cells, and then we use the virus, we put the gene back, it's that yellow thing. We still have to give you myeloablative chemotherapy, really morbid treatment. Kids suffer this, they can die during this, they have serious infections, they have to be in the hospital, and then comes back in, and we're hoping that this goes into the brain. This study took a villa, and these are the centers that enroll in the gene therapy trial. This is published in the New England Journal of Medicine. This is my story in the participation. I'm at the very beginning of the trial with Florian, and this is the patients. This is Mexico, by the way, from that line down. This is called Latin America, and this is the participation on the study. Okay, so half of the patients almost in the study are coming from Latin America. That's how much unmet need there is. You heard Dr. Warshad's maybe in the morning saying the credit shouldn't be to the researcher or the clinician, it should be to the subjects that put themselves through these studies that are very morbid and life-changing. Taking a child from the middle of the mountains in Argentina for 6 months to Boston, not a joke. When he comes back and has a complication and you have to manage them, not a joke. Okay, so again, these people are the ones that need all the credit, not anyone in the front of the room. This is the results, and in reality, we had to compare the treatment to an ongoing natural history. Remember what I told you, the small lesions at the beginning? Really, we're starting to know them, and these are much smaller lesions. So we did that pairing, and still the gene therapy justified the risk because it has a significant effect, and it can prevent you from dying. Not only that, it can keep the lesions from growing. Still, you see, this is at the time of pre-treatment, less than a month before treatment. This is what happens with the lesion. They still grow around, You can see that. So we add a couple of points. This is a lows of 2. This is a lows of 3. And this one, I will dispute it as a lows of 3, but that's what the central gave us. And this is what it would have happened with that brain estimated if it wouldn't have been treated. And this is a 6-year-old. This, by the way, is the first boy that was treated. This is the first one to show the side effects of gene therapy, which is another leukemia type of thing, myelodysplastic syndrome. He required a second transplant. He didn't have a donor when we did this. That's why we did gene therapy. We had to find a donor. Thanks goodness, in those 7 years, there was a donor. So, but 2 transplants, okay? That's a lot of morbidity, in my opinion. Great news, we were able to stabilize the lows. So what about this molecule called leriglitazone? And this is a derivative of another molecule called pioglitazone. And it's been in the world for the last 60 years. It treats all kinds of different vascular types of disease, plus diabetes. It's a drug that you use. This one is a metabolite that is more potent and, in theory, crosses the blood-brain barrier more effectively. It's called the M3 metabolite. And I'm not going to tell you anything about the chemistry. There was a first study in adults that was ideally, the idea was to treat AMN, and that was the primary endpoint. But the lesions in the brain were being evaluated. Central core was giving them scores, and the progression of the disease of the cerebral was also evaluated. And just to say, 30% of the men that participated in ADVANCE have brain lesions. So ADVANCE is 160 patients that were in the study. 30% of them have brain lesions. That's a lot of people with cerebral ALD to study. And even though the study failed the primary endpoint for AMN, did show some effects if you have early AMN. This is what we saw. The diagnosis of progressive ALD, if you were treated versus the placebo. So the patients were, at the beginning of the trial, half of them got drug, half of them did not get drug. And then they flipped and they went into the drug, the ones that weren't getting the drug. So while you compare them to placebo, you were less likely to get cerebral ALD diagnosis during the trial, the 2 years of follow-up. The cerebral lesion progression, if you had a lesion, those 30% of patients, the chances of you progressing in that lesion were less, and that's the central readers. The lowest score was less likely to progress. And this marker that I told you of inflammation or degeneration in the brain, neurofilament light chain that leaks into the plasma, was also diminished in amount. This has been very studied and also correlates with response to treatment. So more about the advanced design, but I think this is the important, going back to the schematic that I was using at the beginning. No lesions in MRI, lesions, cerebral ALD, lesions that start progressing, whether or not with gadolinium contrast, we call it progressive cerebral ALD. And this is what the placebo looked like. So those that didn't have a lesion that became progressive were 15%, and if you were on leriglitazone, we saw that you were 0% chance of doing that. More like granular data on cerebral ALD in advance. This is, again, a clinical trial data, so the best data we can generate. And this is, again, the chances of lesion progression. And then the lesion growth. This is volumetrics. And again, leriglitazone, those patients have a slower or much, much less progressive lesions if you have a lesion. So in total, if you were to put together the clinical diagnosis of progressive, and this was by the investigators that were saying, hey, this patient has a disease that I'm concerned about, the lesions are progressing. And we saw a similar thing. 12% of the investigators ranked these patients that had cerebral lesions that were started to progress, clinically relevant, and 0 of the 58 were considered progressive by the clinician. So even better if you don't use the core read. And then this is, okay, you got a lesion. So do you remember those 30% patients? So 14 in the placebo arm, 19 on the leriglitazone had a lesion. Did any of these guys went into move those lesions to progressive? And the answer was 3 of them if you were not being treated, 0 if you were being treated. So Dr. Michel in France, at the same time she's the PI for the advanced trial, decided to take to the regulatory agency in France a study for compassionate use because she had adult patients that could not qualify for bone marrow transplant because they had lesions that were advanced, or they had lesions that involved the corticospinal tract, or the patients did not want to do transplant. So she tried to offer them the drug that the company made available to them, But she decided to do it the way that she was doing ADVANCE. So literally doing the same evaluations that ADVANCE study was doing on the patients, she was doing it and taking now seriously into account the low scores and the neurological function test and other cognitive outcomes. And you can see it for yourself. These are adult patients, and they seem to be quite stable across a very significant amount of time. This is published in Brain, so I'm not going to go into details, but this is compassionate use. And what's the difference? They did not go through the process of a clinical trial. They were treated like a clinical trial. They are filed in a regulatory agency in France. This is not just I am a hospital and I just give the drug to someone. And then they also have stable lesions, and some of them even shrank those lesions. And this is what Fanny used to always highlight. The cortical spinal tract involvement are those that do worse, and she also saw some stabilization. Again, small number of patients. These are some of the images that she puts out, and this is a lesion, and she hasn't seen any patients in the adult with these kind of lesions once they started progressive to really reduce the size of those lesions. And this is a patient on liraglutide. The truth is some of these patients don't have the full follow-up, and everything that we know and don't know is out there. So there is full transparency of what we know, and we are still trying to answer. What about the boys? This trial is called Nexus. It's ongoing. Now, this is the natural history of the disease. We know the boys go faster, and it's much less likely for a lesion in the brain to stop growing. So if you have a lesion in the brain and you're less than 10 or 12 years of age, your chances of progressing is 90%. Only 10% of them will self-arrest or have no progression. So what happens in Nexus? This is as of the interim analysis. So when all patients meet the 6-month mark, we had to analyze them to see if it was safe to continue doing this study. And this is what we saw, that 3 out of 8 patients that could be evaluated at that time had arrested disease, meaning the lesions haven't grown in that period of time. Arrested disease is a bad definition. We need to start changing that and talk about stabilization of disease. So it's going to be very helpful. So nobody goes to sleep thinking that I don't have the problem any longer. And I know it's bad because you have to go back to the scanner and you have to have this kind of like uncertainty. But I prefer that because we do have treatments when the lesions are small, as you heard. This is a little more data added too, and this is past that point. And again, compared to the natural history, we now have 40% of those patients. There's still 7 patients. It was 8, now it's 7. That are evaluable to the end of the trial. The trial ends in a year from now, less than a year, so all the data will be out. But we have met our objective, okay? The objective was to do better than natural history. And we proposed to do at least 24% more than this, and we ended up doing more than that, and hopefully even more than that. But again, do we save every child and stop the disease altogether? No. I'll give you another caveat of this study. Very hard if you have a transplant in a really good center like France or in Barcelona, and you have a donor and you're ready to wait on a drug to see if the lesions will stop. Putting a kid on the scanner every 3 months and a family having to come back and having a conversation about is your lesion going to be there the next day is really hard. So a lot of families have, and investigators, and we designed the study that way, decided to go to transplant the moment there was a transplant ready. And I think it's totally fine. It's not what the researcher wants, that's what the clinician wants. I want the patients to get the most definite, best treatment they can access. This is what liraglutide, this is very small amount of data. There's more data coming than this, but again, these are the neurological function on treated patients. That's a comparison arm. This was used for the gene therapy approval. That's natural history of neurological function score. This is what happens with this is bone marrow transplant, but we use it for the gene therapy approval. And this is liraglutide. So it compares to bone marrow transplant, not too bad. We did include 2 populations, ones with contrast and ones without contrast. If you go to the LOWS score, this is gene therapy, this is bone marrow transplant, this is liraglutide. So again, you can see the curves here go longer, so we have to wait and see what the length of that effect is. But the question, is there an effect? Is this slowing down the disease? I have no questions, and I'm going to be very blunt on that. There is the natural history of the Nexus patients and the natural history of without treatment, and if you put them side to side, this is what a boy being on liraglutide looks like. So their lesions are growing very slowly compared to how they will do it, according to what we know so far about how these lesions progress, whether or not you have contrast in the lesions. And then this is what nexus look like. A lot of European patients coming to European centers. We didn't activate the centers in the US for several reasons, but it was at the moment, gene therapy was also still ongoing. First patient got enrolled in the middle of the pandemic, by the way, just at the beginning. But this is, again, the same story, okay? I'm just showing how the contribution, and I'm not putting some of the African and some Asian patients that also participating, but the contribution of having this massive unmet need. These patients and these families will sacrifice a lot to try to save their boys. This is an MRI on a patient in Nexus that had no contrast. And then you can see the lesion over 2 years doesn't grow significantly. It looks almost acceptable to what you would expect if you were treated with bone marrow transplant. This is a patient that had a contrast-enhancing lesion, and this is follow-up up to 12 weeks, so it's a very short follow-up. We did have this patient going to transplant. This is one of the stories where we see the contrast not resolved, but much improved. We see the lesions kind of even shrinking, almost like the edema, if you want to, or whatever, the swelling is kind of being contracted. But the patients opt to do bone marrow transplant, and I think that's okay. Because if you have a definite treatment, go for it. But if you don't, or if you were somewhere else and you got this MRI, put me on leriglitazone, and I hopefully get to this way to transplant with a very small lesion that has the best chances of having the best prognosis. So just to make the point that the treatment may have another patient that went to transplant, contrast enhancing, a different type of lesion in the front, but you can see the lesions almost didn't move at all. And the patient post-transplant has progression of the disease, which is expected, as I was telling you, but I wanted to show this because 8 months after transplant, what it looked like at the time of transplant, he still has that lesion progress, which is expected and part of the evolution. I'm going to skip this. There is a lot of more sensitive markers to go after. But they're all exploratory biomarkers. This is a neurofilament light chain compared to the transplant. What about safety? Safety profile seems pretty acceptable. This is the adult safety profile. Some edema, persistent, weight gain, very well tolerated. A lot of drop-off until the patients heard that there was some benefit possibly for cerebral ALD, but by that time the study was ended. A lot of patients came back trying to ask for compassionate use. Some of them have gotten into compassionate use, and some of them have continued the drug, and that's the point here. It's a long period of exposure to the drug. Now we have years of exposure. We know at least this far is safe. It's not causing major side effects, and I think these side effects are much less than what you get when you're doing a transplant. So again, this is advanced. And this is our nexus, kind of like all summarized in one slide. So we see plateau. We see a significant number of patients behaving very different than natural history and even arresting the disease by the current definition. Are we doing more? Yes. We want to see in a real study in adults, that's calyx, if patients that have these aggressive lesions are going to start moving, the contrast-enhancing lesions are going to benefit from the drug. It's a 3-year study. We're completing Nexus. I told you there's 1 year to go. And then there is something that you do after a drug goes into the market, hopefully at some point, which is monitor these patients that are in the drug. We put this in front of the regulators, and we just call it the fun fact in PowerPoint. This is funniest one. So the fact, more than 50% of adults with ABCD1 develop progressive cerebral ALD. In the advanced study published in Lancet, the results showed significant reduction in conversion to progressive cerebral ALD. Median survival of a man with progressive cerebral ALD is 3 years. And then we know that in compassionate use, which is now published in Brain, that there is radiological stabilization, that some of these patients don't need any longer a transplant. And the totality of the data in terms of safety says that it's safe up to 6 years with leg edema, which is manageable, and weight gain, which is desirable. Desirable because this is cerebral ALD, this is not AMN. So these patients are cachectic. They're in hypermetabolism. They lose weight. So if you give me a little bit of extra weight gain, that wouldn't be bad. That was a question from Fanny. to the regulators. This is my one, trying to tell them it's not a spinal cord disease. Cerebral ALD is a disease of the brain. That's my schematic. 90% of boys will go on to progress. So far in Nexus, we see 30%, more than 30% of these patients that are arrested at 2 years. That's what is considered the long term for now. MRI stabilization is clinically meaningful. More than 80% of the boys with ALD will progress to rapid progression, and we see MRI lesion stabilization. Less than 20% of these boys with ALD are eligible for allo. Less than 20% of the boys are eligible for allo. That means you have to find a donor, you have to be in the right window, the lesions have to be small enough, you need to have the money to afford the transplant if you don't have a healthcare system. Largely secondary to delays in accessing the expert centers, some of that. And then this is what I think is the main point. It's a pill. It's a liquid for the kids. You can take it the moment that someone tells you, after newborn screening, that you have a cerebral lesion in your brain. And then be on it until you get to be assessed in a center of excellence for leukodystrophies. It might take you 4 to 6 months. Average in the US, you saw it yesterday, is around 4 months. Average if you're not in the US is more than 8 months. So anything that we can do to keep the lesions smaller, great. And some of these patients will not meet criteria for transplant. That's kind of really good news for the boy, really bad news for the family and the boy in a way, because they have to continue being screened very regularly and very frequently, which is very unnerving in a way. And I acknowledge this because it's very hard to be put into the, like, my boy has a lesion in the brain and we are in a new treatment that we have to end. Okay, that's it. So that was the last one. We have other treatments that have been approved on an open label on a much more morbid disease. So with that, I think I will end now. Thank you.
Okay, thank you, Patty, for this big overview. There's a question over there. Okay.
Yes. Sorry. So, in relationship to these studies, and I know that people say very casually all the time, usually the people who get ALD also are adrenal insufficient, the males.
Yep.
Very high percentage of them are. In any of these studies, I mean, is anybody, I mean, I know they are, if they're already taking the cortisone replacement along the way, so somebody's monitoring that, but is that being recorded and looked at as
Yes.
opposed to, because is there some point where it doesn't matter to replace the cortisone anymore because nothing's going to help it until you have the transplant?
So
Or do you keep doing it?
So we monitor everything, and we have the data, and all the patients continue their cortisol and hydrocortisone and the treatment for adrenal insufficiency. I want to say something very clear. Bone marrow transplant, gene therapy, leriglitazone, none of them treat adrenal insufficiency. Doesn't go away, never goes away. You'll be on hydrocortisone most of your life. It's very, I still have to see a patient that comes off hydrocortisone.
So are there any cases where people... So do you have patients coming in who have not been on cortisone replacement because they didn't know they had this, and now you have to start it? I mean, I think that we've seen many of the people, particularly 10, 20 years ago, they would have an adrenal crisis, and that would kick off their ALD. So you are now saying, yes, you must keep doing the cortisone replacement, but what about getting it started in the first place? So, for example, with the newborn screening, I think we need to maybe get all the pediatric endocrinologists on board with, we got to get this cortisone into these kids right away.
Completely agree. The treatment of adrenal insufficiency starts at the moment you have the diagnosis of ALD and you check your cortisol and you see the deficiency. Newborn screening has the recommendations are very strict. So these patients immediately go into monitoring their adrenal gland by an endocrinologist. Okay? So if you are in newborn screening, we're good in theory. You should be good. But if you don't, and you are in a family or you're a relative of someone with CALD, you do have to see an endocrinologist. And I wouldn't even wait for cerebral ALD or not to present or AMN. No, you need to see an endocrinologist. Boys or males out of 5 with adrenal insufficiency in 1 is ALD. This is very high incidence for the disease that is common to their practice. There was a mom that toured the entire country a few years ago out of ULF collaboration to raise awareness across pediatricians and endocrinologists about adrenal insufficiency and ALD.
But so now, though, are you finding that more of your patients have had it by the time they come to you?
The diagnosis and the treatment, I would say yes. Yes. All the boys that we have in the trials are being treated. Yeah.
Okay, I would suggest to make a short break, 10 minutes, so we meet again here at 12:30. Please. So we follow our session right now with Amina Smith-Fine from Baltimore.
Yes.
And you're talking about sway amplitudes? Mm-hmm. Okay. Yeah. That's a new technique, right?
Yes.
Yeah, okay. No, proud of you.
Can everyone hear me okay? Okay. Great. Should I give it any more time, or you think we're okay? All right. So good to see everyone. It's always a pleasure to be here at this meeting. I'm Amina Smith-Fine. I'm a neurologist at the Kennedy Krieger Institute in Baltimore, Maryland. And I'm a member of the ALD Connect Board of Directors and also an investigator on several multi-center clinical research projects for adults with ALD. So, today I'm excited to talk to you about sort of one of my main interests, which is trying to explore how we can link quantitative measures of walking imbalance, which we've historically gotten in the lab with really sophisticated equipment, and now more recently with wearable sensors, but basically how we can link those measures to outcomes that are really more important and meaningful to ALD patients in day-to-day life. Okay. So the main question, what symptoms can we measure that are clinically meaningful to patients? We have to really start back at the source. So as some of you might know, 2 summers ago, actually, there was a patient-focused drug development meeting that was hosted by ALD Connect, and this was a really important forum for patients with ALD, adult patients with ALD, and caregivers to come together, share their stories and experiences of living with ALD, what they hoped for the future and for treatments with ALD. And this was in a large forum together with the FDA, with industry partners, clinicians, scientists, sort of all the right people in the room. And that nature, the type of meeting is always really important to advance new clinical trials. So one of the things that was really useful that came out of that is patient and caregivers were given a series of polls where they sort of really ranked things of importance to them. So I'm going to revisit some of those results as a starting point, and then talk to you about an ongoing study that's actually being conducted in the US and in the Netherlands, where we're doing repeated assessments of walking imbalance of patients with wearables, and also trying to understand how that impacts day-to-day life function. So the initial results of that study were just published in the Journal of Inherited Metabolic Disease last month. So I'm going to show some of those published figures. First, looking at what we know now about relationship of sway and gait with ALD disease severity at a single point in time, and the relationship of sway and gait with meaningful clinical outcomes. In this context, I mean assistive device use, so things like crutches or a walk aid, another type of walk aid, falls, which is something that I hear in my clinic often as being problematic, and then quality of life. So then I'll just end by a summary, and then just talking about our next step forward across our sites for advancing this research. Okay, so going back to the patient-focused drug development polls, the first question was, which of the following ALD-related health concerns have you or your loved one ever had? So this is lifetime, select all that apply. And possibly not surprising, at the top of that list were balance issues and altered gait. And then the next question is similar, but there's a subtly important difference here. So select the top 3 most troublesome ALD-related symptoms or concerns that you or your loved one have ever had, and they selected up to 3. And so again, topping the list are balance issues and gait, as well as spasticity and incontinence. So we're sort of getting a sense that these things are really important. And then what specific activities of daily life are important to you that, or your loved one that you're not able to do due to the ALD. So how does this really inhibit you? And walking by far was the most common concern, reported by about 70%. And then finally, what worries you the most about you or your loved one's condition in the future? Select the top 3. And so losing my ability to walk was up there, in addition to concerns that my symptoms will get worse, and of course that I'll develop cerebral ALD. So I think, you know, for me as a neurologist, thinking of the importance of walking in balance, it's intuitive. It's something that comes up at probably every clinic visit that I have with patients. You know, people want to know how fast is this going to get worse. We have conversations about whether a walking aid is needed. These are really kind of top of mind. And, you know, actually I'm going to go back one slide to say that amongst other things people report, so things like spasticity or tightness, weakness, sensory changes, foot drop, if you think about it, really all of those signs and symptoms you know, can contribute to walking in balance being a challenge. Okay, so again, this is an audience that's well aware that it's important to monitor the spinal cord disease progression, not only, you know, looking for cerebral disease, but looking at what's happening with the spinal cord. And I've already sort of shown this is top of mind for patients. And then from the industry perspective, you know, for us to have trials in AMN or in adult ALD, we need to know that there are sensitive measures that are important to patients that change in a short amount of time, you know, 6 months, a year, 2 years. And this is a challenge because, as you know, there's a great variability in the way that this disease presents. You know, even 2 people within the same family with the same, you know, gene variant change could look very different, progress very different. So it can be slow, it can be unpredictably very rapid. And so right now, we have sort of well-used clinical scales to capture this, things like the EDSS. They're commonly used. They can be really good at understanding how severe the disease at a single point in time, but they sort of really fail if we try to monitor these variable changes longitudinally. They're really not susceptible to subtle changes. So we really need more sensitive and accessible outcome measures that can quantify the spinal cord changes and that manifest as the gait and the balance problems. Okay. So in the recent years, the wearable sensors have become really a practical way to try to address this. And it's nice because it gives the flexibility of being able to monitor these things at home or in the clinic, and it doesn't rely on really expensive equipment at a specialized center. It's pretty user-friendly for either participants to learn how to set things up at home, and it's been actually really easy to train new staff to administer the wearables test. You can collect data more frequently. Again, if we're sending it to your home, we've had really good success sending it every 6 months or every year, or just doing it when folks come into clinic. And it helps remove some of the participation barriers. So if because of physical disability or cost or time burden, you can't come in, this is an alternative. And then I think one major advantage is that these tests, we don't just sort of passively send these monitors for you to do it at home yourself. They're supervised directly by our research staff in real time, so we can kind of really know the data is high quality and reproducible. So we use the Opal's system of wearable accelerometers. These look basically like a Fitbit, and they go on the waist or the lumbar area and on both feet for a quick series of tests. All of this is about an hour usually to do, plus gathering history. And the Opals have been around for a while, actually, so there's at least 15 years of good data in Parkinson's disease, multiple sclerosis, other ataxic disorders, so we're not breaking the mold doing this in the leukodystrophies. And so essentially what we send out for the remote tests would be this Opal's kit, a remote-controlled web camera, a laptop, and a device manual that sort of explains how to do all the setup. And this is sort of a picture of how it might look at home. But again, depending on the site and the needs, we can do this both in the clinic and at home. Okay, so I'm going to show the next several slides are going to be focused on figures showing how gait and sway measured with wearables can reflect disease severity in ALD adults, and then that they are linked to clinically meaningful outcome measures in ALD. Okay, so demographics or who participated in our study. I'm going to be just showing you baseline analysis of this ongoing study. There are about 120 men and women who participated, both at the Amsterdam University Medical Center and Kennedy Krieger. And so we have cross-trained and follow a single standardized protocol across our sites. And the opals generate a lot of variables, over 100, but we are focusing on a selection of those. So we try to make it hypothesis-driven. We're looking at the ones that we think would be important based on what we know about pathophysiology of AMN. And then also which ones yielded the strongest relationships in our regression analysis. So looking at, again, who is participating, we have, so the men are in blue and the women are sort of in this pink-orange color. And so for them, starting with the men, we have pretty young men here, and the women tend to be of an older age. And this is not surprising, thinking about sort of why people present to clinic. So, the men sometimes for their annual MRI surveillance, even at the point at which they're asymptomatic, and we know that a lot of times women don't manifest many symptoms until over the age of 40, and they might also be presenting because they have a son who was recently diagnosed. So that's sort of the reason for the age differences we see. And again, the men, we have a lot of men that are asymptomatic here with a disability score of 0, and also with higher scores closer to 5 to 6, whereas the women look a little bit different. They, their scores are really kind of in this middle range. Okay. So in terms of sway, we measure that from just a single sensor at the waist. And we do, there's actually a few conditions, but I'm going to focus on the feet apart, eyes open condition. So this is 30 seconds of standing. This is the easiest thing to do. And then also the feet apart, eyes closed, which is, if you might know this from neurology clinic, it's pretty challenging to close your eyes and stand still for a prolonged period of time. And this is because of the dorsal column changes in the spinal cord. So that affects the sensory input or proprioception, so the sense of where your body is in space if you don't have visual guidance. So here's a diagram looking from the top down. The blue is sort of looking at sway area, and so of course you can either sway front to back or anterior posterior or medial lateral, which is side to side. And this is an example of a leukodystrophy patient's sway path over 30 seconds. You can see there's a much larger sway area than the healthy volunteer here. Okay. So first, we see that sway is correlated with the expanded disability status scale, and this is for both men and women. So RMS sway is a nice approximation of the sway amplitude, which we get on the force plate. That's the gold standard test. And so you can see clearly that the higher the disability scale score, the greater the degree of sway, and this is more significant, or it was a stronger relationship in that feet apart, eyes closed condition, but we saw it across both, which is good because sometimes it's people sway so much that they can't complete the eyes closed test. So it was good to see differences in both areas. And then for the women, it didn't matter if the eyes were closed or not. There was still significant sway, just to a slightly more modest correlation than we saw for the men. Okay. So then in terms of the walking test, we did a couple different tests. So Amsterdam had started doing the 6-minute walk test. Some of you might be familiar with it. It's very strenuous, it's fast-paced, it's a long duration. And so that obviously is challenging people to their max ability. At Kennedy Krieger, we do a 2-minute walk test. So this is self-selected pace. It's good because more people can do it. You can do it with a greater amount of disability. It's less strenuous, and it also works really well at home, and it's safer at home. So we've since been trying to, at both sites, to do all of these walking tests because they give you slightly different bits of information. And then the opals collect during the walking 16 different variables, all based on where the foot is positioned in space during the gait cycle. So the gait cycle is this period where your heel first strikes down as you're starting a stride to the next time that the heel strikes down. So we found that gait speed also was well correlated with the disability scale score. And you kind of see especially tight relationships for the men. So for the 6-minute walk test in men, you know, again, it's very clear that the higher your disability level, the slower your walk speed or your gait speed. We didn't see a relationship for the self-selected pace test at Kennedy, but we think this is because at that moment in time we had less men participating. We have more data we're evaluating now. And then for the women, we saw that gait speed was also correlated well with the EDSS, and it was regardless of condition, both for the fastest possible and the self-selected walk tests. Okay. Toe-off angle is something that's interesting. Like, I don't think it's really been reported before. It's one of those more unique variables that the OPALS gets. And so what that is, sorry, this is like a small picture, but it's like this blue area. So when so basically, if you're initiating a stride, it's the angle that the toe makes at push-off as the leg is about to swing forward. And just for perspective, about 45 degrees is what that angle should be. So we saw that the toe-off angle is very tightly correlated with the disability score. And actually sort of for the men who had a very high EDSS, the toe-off angle was decreased by about half. And so we saw this also for self-selected walking, and that relationship was still there looking at the toe-off angle for the women. And so this is one that there are several factors that might go into that. So your toe-off angle can decrease if you have weakness at push-off. It can also be decreased if you have a lot of spasticity or tightness, limiting your range of motion at the angle. So we think there are a number of reasons why this is significant. All right. So next we looked at two groups, people who use a walk device and those who don't. And we wanted to see the people who use a walk device, do they also sway more? And so we found that looking at 3 different ways, 3 different variables of sway, either that sway amplitude, the total sway area, and the anterior, posterior, medial lateral planes, and then that total path length of the sway, that there was a big difference, for those who needed a walk device versus those who didn't. And we also saw this clearly for the women. This is sort of intuitive, but gait speed also differentiates use of a walk device. So you would imagine you're going to walk slower if you need a device. That wasn't so surprising, but just I think the magnitude of the difference is what's interesting here. So for perspective, about 0.1 meters per second difference in walk speed is most people, that's correlated with quality of life and many other neurologic disorders where there's walking dysfunction. And this is a difference of 0.8 meters per second for the men and 0.6 for the women. So really the speed is half if you need a walking aid. Okay. Sorry, there we go. So we next looked at falling frequency. This is just another important thing we talk about in clinic. There's, along with falls, there can be injuries, and that can really set people back with their disability. So the Amsterdam group actually queried males every 2 weeks. Actually, they're still doing it. I'm amazed that people are answering the surveys. But every 2 weeks, there's an automated questionnaire that goes out asking, did you fall, yes or no, over the past 2 weeks? So 25 of almost 40 participants had falls, 14 reported no falls, and we sort of looked at what are the relationships first with sway, and we did see there were significant correlations, although pretty modest, for feet apart, eyes open, and feet apart, eyes closed condition of sway with the falling frequency. And then for gait, that was a stronger relationship. So basically, the slower you walk, the more likely you are to fall. I thought that was a little bit interesting in part because theoretically some of these men that are walking slowly use walk aids, but they're still falling. Okay. And then this is the last measure I want to talk about is the quality of life. So again, males at AMC were asked about, it's a questionnaire asking about a few different domains of quality of life. And what we found looking at that in sway is that 4 of 8 domains were correlated. In order of strength, physical functioning, which is your limitations in your daily physical activity. We saw a relationship with general health, which is how people personally rated their health, how they compared it to their peers, and sort of thinking about their expectations for the future. We saw that energy or fatigue scores were associated with sway, even though to a milder extent, and then bodily pain as well. Okay, so I hope, I didn't want to take too much time, so maybe hopefully there will be questions, but you know, hopefully I've been able to show you some convincing evidence as a start that these gait and sway variables that we get with the wearables are important, that they're clinically relevant for patients. And then we're sort of next in this phase of exploring how they do longitudinally. So we have a lot of patients who've done this 1, 2, 3 years, and we're now at the point of analyzing that for men and women, both at Kennedy, AMC, and also we have some data at MGH. And so we're going to also explore more of those questions about quality of life, falls and tripping in women. And hopefully that'll be at the next meeting. We'll discuss some of those results. So thanks again for time and attention, and to our project team across sites. Several of those people are in this room, and just really looking forward to the next phase of this project. Thank you.
Thank you. Thank you, Amanda. There's a question. 1, 2 questions. First.
Hi, this is a great presentation, and great to see that digital technology is being used for this patient population. With the advancement of digital wearables like the watches, Rune Labs has some applications and technologies that are being applied to Parkinson's disease studies.
Yeah.
Do you see this technology being used for these patient populations, and do you see in future clinical trials for childhood cerebral ALD or other patient populations the digital technology being used?
Yeah. I mean, I can say that so digital technology already is being applied to some clinical trials in leukodystrophy. Yeah, like, or at least, sorry, I'll say natural history. That's sort of either concurrent or leading into clinical trials. So it is being picked up. I think a lot more people are sort of noticing it and understanding kind of the utility. Did you mention a particular system?
Rune Labs, RUNE.
I haven't heard of it. I will say Parkinson's disease kind of leads the way. The opals came out of it's in the name, Parkinson's disease. So again, it applies to many neurologic disorders, and I hope there'll be more uptake. Yeah.
Great, thank you.
You're welcome.
So with the sway, is that more due to muscle weakness, like an inability to correct the position in space, or is it more of a sensory or proprioceptive issue?
That's a great question. I mean, our sense is it's multiple. It's all of the above. Yeah. I mean, 30 seconds is a long time to have to stand, so weakness could absolutely affect that. Spasticity, so sometimes cramping or spasms that people have trying to stand for a while. And then absolutely, that's why we see consistently usually the eyes closed conditions and more sway. We think that's directly because of the proprioceptive changes. But we're doing imaging and a lot of other quantitative tests in the lab to try to support that and understand exactly where the changes are coming from. Yeah, you're welcome.
Okay, thank you again. So we start now with a new issue. It's improving quality of life in symptomatic women, and Dr. Lisa Schäfer from Leipzig will present her data. Please go ahead.
Can you hear me? Thank you very much. My name is Lisa Schäfer. I'm a psychologist at the Leukodystrophy Outpatient Clinic in Leipzig, Germany. And I'm very happy to be here. It's my first ULF. And I'm delighted to present to you today our research, what we do in Leipzig on symptomatic women, and also studies with the aim to improve the quality of life of symptomatic women with ALD. I think I can make this short because we have heard already a lot about that. So women with ALD can develop symptoms of myeloneuropathy, and usually with a later onset in life compared to men, starting at the age of 40. And as we also heard before, adrenal insufficiency and also the conversion or transition to cerebral ALD is very rare, with less than 1% of cases reported so far in the literature. Nevertheless, yes, women show or have a milder course of the disease, but besides of the neurological impact on the quality of life, I see also that there are different burdens that also affect the quality of life of those affected. So this ALD is a rare disease, which means that women often report that come to our leukodystrophy center that local doctors around the area have no idea. They even don't know the disease, and so they don't have the expertise about this disease, and often they also have the prejudice that women with ALD are pure gene carriers and they don't develop disease, so they are often not taken serious in their complaints, and which is really hard for the women. And further, myeloneuropathy is a progressive, incurable disease, and for that reason, we can't make or we can't predict the disease development in an individual, and this also triggers a feeling of loss of control in individuals affected. And this also has an impact on the well-being and the mental health of the individuals, or can have an impact. And ALD is a genetic disease, which means that usually there are more than one family member affected by the disease. Many women in our leukodystrophy centers are mothers, and they have a child, a boy, that has cerebral ALD, or they even have lost already boys to the disease. So I think there are different topics or burdens playing a role in this disease. For instance, loss and grief, then also the health concerns. So there's actually some data showing that that the concerns about the health of other family members affects more my well-being than my own disease severity. And also take care of affected family members also has an impact on the financial situation of the family, and also on the social participation of the caregivers. So there are many burdens, and that's why we decided to invent a multi-professional lifestyle intervention which has an easy access for symptomatic women with ALD to higher their quality of life. And this study is called SMART ALD study. We started it 2 years ago, and the study was funded by the European Leukodystrophy Association, or short ELA International, and was conducted under the direction of Dr. Wolfgang Köhler at the Leukodystrophy Outpatient Clinic in Leipzig. Within this study, we offered symptomatic women this lifestyle intervention, SMART ALD. And SMART ALD was multi-professional. That means besides of disease-specific neurological counseling, we also offered psychological counseling, social, nutritional counseling, and disease-specific individual fitness training. And this was also easy accessible, as all the sessions within this lifestyle intervention were online via video calls. So the participants, or the women, symptomatic women, didn't have to come to our center in Leipzig, so that we could include women all over Germany into the study, and also other German-speaking women from other countries. So we had also participants from Austria and from Switzerland. So it was web-based and it was individual. That means that we offered these different counseling offers, but the participants could decide which counseling offers they want to choose, or in which they want to take part in. So it was not mandatory, and if somebody says, okay, I have a local psychotherapist, or I have nothing what I want to talk, or there is no problem, psychological problem, then it was okay, so they didn't have to have an appointment with me. I will tell you something more about this different modules. So all our participants received at least 3 neurological consultations by neurologists at our center experienced with XALD, and the neurologist made treatment recommendations, and they should be implemented together with the local doctors. And also, if the local doctors had questions, something is unclear, they had the opportunity to call our neurologist or write them an email if they have any questions through the disease and the treatment. Further, I offered psychological consultations, and it was an offer, so some participants decided to just have one session with me, and maybe had and she had specific questions, for instance, how to find local psychotherapy, or how's the process, how does it work. Some participants had a specific topic, for instance, coping with the illness, or the grief over losses. But also there were also some patients who didn't have a specific topic, but they wanted to benefit from this possibility to have a protected space or room where they can talk about about things which they wouldn't talk with their relatives about. Then we offered nutritional consultations. So we gave the latest update on dietary recommendation to reduce the intake of food rich on very long chain fatty acids. And we also asked to keep a multi-day nutritional log, so that based on that our nutritionists could make recommendations. So an individual evaluation was possible, and also Marie gave some ideas, inspirations for alternative suitable foods. So she on a regular basis she sent it out recipe suggestions via email. And if people or participants used or were interested in social work, then our social work, Britt, our social worker, evaluated the current status of the participant regarding their social medical care situation, and if she saw any gap, then she gave the participant information about state aid, and if required, also actively assisted with the application process, which is really complicated in Germany, as we are also a federal state, and the rules and applications really differ from state to state. And last but not least, we also offered this fitness training, either in single setting or in group setting. So this was also up to the participant, what she prefers. And a session was around 45 minutes. We offered them weekly, but we also had participants who took or who used the fitness training twice a week. And we also produced fitness videos. They are on YouTube. The idea is that we wanted to give the participants instructions for a self-guided training, so after study end, that they can continue with the training, even after the study end. And as you can see, we always showed two versions of an exercise. So we tried to have exercises for instance, for balance disorders that can be adapted to the fitness level of each participant, because we had really a great range of women with different severity levels. So some were already in the wheelchair and some could easily walk without aids. This is our study design. So we were able to enroll 68 symptomatic women with ALD, and we randomized them into 2 groups. An experimental group which received 12 months of this intensive additional smart AD lifestyle intervention offer, and a waiting list control group who had to wait 6 months, and after this 6-month waiting period also received this more intensive lifestyle intervention. And this 2-group design was necessary as we wanted to test the effect of this smart ALD intervention on the quality of life. And this assessment point T1 was very important because this is the time point when the experimental group already had received 6 months of smart ALD, while the control group didn't have any treatment or had treatment as usual. These are already the results. So from the symptomatic women who were in the experimental group, so who received the smart ALD intervention, the most participants took advantage of social counseling and nutritional counseling. Over half of the participants also used the fitness training offer, and 38% had at least one psychological counseling session with me. And on this graph you can see the number of modules taken at the same time. So most participants used 3 intervention models offered at the same time, and there were only a few patients who only used one of these additional offers, and even less participants who just used the neurological counseling without this multi-professional other offers, for instance, nutrition, social work, psychology, or fitness training. Now I come to the results. As I said before, our main outcome was to see if the quality of life is getting better, the self-reported quality of life in the participants who received the Smart ALD program in comparison to the control group. And we assessed quality of life with a questionnaire. We have seen it before. This is this questionnaire SF36, which assesses quality of life in different domains. And as you can see, we had a significant improvement in the group which had received 6 months of Smart ALD regarding self-reported vitality and mental health. So the higher the values, the higher is the quality of life, and you can see the values are really increasing in the experimental group, and compared to the control group where the values remained stable, so no improvement. And these are the effects which are statistically significant. So you can really say there's a controlled group. Okay, this is really or should be the effect of this additional Smart ALD intervention. We also saw in other domains, for instance, general health, that this was also improving in the group which received the 6-month Smart ALD intervention, but this was also the case in the control group. I will come to that point, or what my interpretation is for that. And we also had some secondary outcomes. So there were more questionnaires we asked the participants to fill out about their general health, physical health, mental health, but also we gave them fitness tracker to wear the whole study, and which assesses their physical activity per day, and also asked them how satisfied they are with the current treatment. And also here we had significant effects of the smart ALD intervention. So the knowledge of disease-specific nutrition increased, also the knowledge of social medical benefits for disability increased in the receivers of smart ALD lifestyle intervention compared to the control group, and also the physical activity per day, the intensive physical activity per day increased in the experimental group after 6 months smart ALD participation. And also here, so these are the significant effects. What is not significant but still interesting is that, for instance, depression scores decreased over time in the experimental group and self-efficacy increased. But again, these improvements could also be seen in the control group. And my idea is that it was a waiting list control group, so they knew that after 6 months waiting, they will also get this more intensive treatment, and maybe just this expectation and the hope that there will be something coming up might already have a positive effect on the well-being. So this is my interpretation, at least. To summarize, an easily accessible, multi-professional, disease-specific lifestyle intervention has the potential to improve the quality of life of symptomatic women with ALD. And I think in general, online programs could be a good alternative to intensify the care, especially for people with a rare disease who live far away from a specialized center. I think I'm done, and I want to thank, of course, my team, Wolfgang Köhler and Caroline Bergner here, all the participants who took part in our studies, also in other studies, and of course ALA International, who funded this research. So without this funding, it wouldn't be possible to do that. Thank you.
Yeah, thank you very much, Lisa. Very nice work. Yeah. So there's actually Keith.
That was great. I like that a lot, Lisa. That looks like a lot of work went into that. So congrats on organizing that, conceiving of it.
We also had, as you see, a multi-professional big team.
Yeah, right. Yes, to you and the team. But it's an amazing amount of work. But I have to say, it looks like it would be a relatively low-cost intervention too. Could you comment on how much it might cost in the average, healthcare system, and then also how kind of portable this would be for other centers to try to do, right? Language aside, but
this is a good point, and this should be the next step. So this is kind of a pilot study. So we're just testing the feasibility, the acceptance. I didn't talk about acceptance, but it was really high. We had a very low dropout rate in the study, and also the evaluation of this whole program. I didn't present it because of time problems, but I think it was really good. And yes, we wrote down how much everybody had to work, how many hours for each patient, and what we also make sub-analysis for which patients it's not working, this online program. But I guess, this is something for the future work, really to say, okay, how high are the costs? But I think, we have to see it in comparison. I mean, otherwise, how high is the cost to be in psychological treatment, or, you know what I mean?
Yeah, I mean, it looks like a neat idea. So I can say that I can't speak for my colleague who sees adults, but I think probably many will be interested in expanding something like this. And were there self-assessment tests or like questions at the end of the modules where people would watch the module and then take like multiple choice question.
Sorry,
Would people do multiple choice questions, like a little test at the end of the modules?
Yeah, I mean, this where most of the outcome was self-report questionnaires, and this are usually, or what? I didn't get it
to
right.
test knowledge. You know, for some of them, some of the modules are educational and about nutrition.
You mean if what the education level was, or of the participants?
To test kind of retention of knowledge.
No, I think no, we didn't test it.
Just curious, yeah.
We did not check if they have an increase of knowledge with the let's say.
You mean like if you ask them questions about, for instance, ALD specific diet or what they can eat or not, or no? It was just how they self-rated their knowledge, if it has increased or not, what their impression was.
But it's surely, let's say, less cost-intensive than consultation directly. But of course, you have to take into account it also takes some time. But usually, let's say, online is more efficient. Yeah. More questions? If this is,
I'm sorry if you mentioned this at the beginning. I think it's great that you started with a women-forward approach to this. Since you have seen benefits, are you considering expanding this program to symptomatic men as well?
Yeah, that's the plan. I mean, I'm still analyzing the data and want to publish it, but at least some parts of the program, for instance, the fitness program, this is actually an idea to offer it to all men and women with myeloneuropathy, because the feedback was very good, and as you can see, we have also a separate analyze just for this fitness program. There's also a poster outside. Yeah, so this is really an idea to make a bigger follow-up project out of that.
My question
I'm still here till tomorrow.
It's just about a clarification of neurological counseling, kind of what that is, and then you said they would put the people on the appropriate neurological treatments. What would those be?
Okay. Well, this is because some had pain and never treated for pain, some had spasticity, never treated for spasticity or restless leg syndrome. So we're asking for these. And if this is present, then we can recommend that they should go to your local doctor and get some medications for that, for example.
But that's part of entering into the study.
No, it's in the study. You know, in the study you have an online doctor.
Everybody has that. I mean, who starts with the smart ALD intervention. So the control group didn't have it in the beginning, but after 6 months, getting a feedback.
Yes.
Okay, I think we have to proceed. Thank you again. Jeddah Lee is now presenting.
Sorry, I need help getting this because my computer doesn't recognize this for some reason.
Oh.
I cut my presentation down last second, so. Is that on?
So I guess Jeddah is also talking about women with ALD and restless leg syndrome, which is obviously a problem in many of the women, which we did not recognize maybe enough for many years. But now there is new data on it, and then I think there's a good reason for treating these problems. Yeah, Jeddah, you may start with this, and then I think you're also talking about some gene therapies. Yeah, do you? Okay.
Yes. Hi, everyone. So I am actually giving 2 talks in Florian's place, Dr. Eichler's place. So I have big shoes to fill. And for the sake of time, to get everybody out on time, I actually just sat there and cut my presentation. So I apologize in advance if something happened to the slides. Okay. How do I advance? Oh, this is going really well, as you can tell. All right, let's try this. We got the pointer, sort of. Okay, good. We got that. Okay, good. All right, good. Short slide there. Studies. We're going to talk about 2 studies today. Ladies first, so we're going to talk about the restless legs study first. So the takeaway from this slide is that before, as you just mentioned, people thought women did not have symptoms, which is definitely not true. And now there have been tons of studies that have confirmed what I'm sure the women in this room know, that women have a lot of symptoms, and it is actually a very significant burden. So we did a natural history study, both a retrospective study, meaning looking at patients' charts, as well as a prospective study interviewing patients to try to really get to know the symptoms that women have. And in light of the restless leg syndrome, why we thought that was really important to study is that if you look here, pain is a huge component of patient symptoms. And that's a huge component of an initial symptom that women have. Here we have the impact on quality of life, and unfortunately most women report that their symptoms have severe impact on their life. And it's not just symptoms. If you look at the contributors to negative quality of life, 71% said there's a diagnosis in a family member, and 65%, so coming in close second, are the physical symptoms that women actually experience. So let's talk about restless leg syndrome. Restless leg syndrome is a medical diagnosis that affects many women, including women who don't have ALD. And there are, women with ALD are a little bit different in that there are symptoms that can mimic restless leg syndrome, and a lot of lower extremity symptoms that are hard to distinguish whether it's restless leg syndrome or not. So part of what we're doing in this study is trying to characterize all the lower extremity symptoms that women have, and really trying to figure out, do we have the correct diagnostic criteria for women with restless leg syndrome who also have ALD and those symptoms, 1, and 2, can we treat the restless leg syndrome? So this is kind of all the components here for leg discomfort that women with ALD experience, and it's due to a combination of neuropathy, spasticity or stiffness, vascular problems, and then your classical restless leg syndrome. So restless leg syndrome, the mnemonic to remember what this is urges, because the most important is an urge to move your legs as much as possible, and it gets worse if you sit down for a long period of time, and it gets better if you stand up and walk around. And one of the hallmarks is that these symptoms tend to be worse in the evening or at nighttime, and usually these symptoms are not explained by any other disorders such as iron deficiency, which is the most common. So here, I really like this cartoon because it really shows you all the different ways that women can be affected by restless leg syndrome. And if you ask different patients, they'll describe their symptoms differently. And Dr. Winkleman, who's our sleep specialist who specializes in restless leg syndrome, actually said that the most common and the most specific description is, "I can't describe it." That's what we usually hear from women, is that they can't describe that sensation. Okay, so why we really care about restless leg syndrome in women with ALD, it's because women are disproportionately affected compared to men. So about 50% of women, let's see, 20 patients, this is number of patients. So we have 20 patients here who, the pointer stopped working, okay, who experience symptoms, who are women, and only 10 in this particular study, so almost twice as much women as men. And you can also see that, sorry, I'm like trying to read this. In the general population, only 5 to 10% of patients experience this, whereas in the ALD population, 40% of patients experience this. And here, dark blue is people with RLS, and light blue is people without RLS. Sorry, that's really hard to see. But the takeaway here is that if you have RLS, it actually increases your risk of having all these other symptoms as well. So moving on, our trial design. There are 2 phases to this trial. The first phase is the part of the trial where we're really trying to understand these symptoms and trying to understand what types of symptoms these women are experiencing. In the second phase, we are basically testing this drug called pramipexole, which is already approved to treat women in general with restless leg syndrome, not specifically for ALD. And we want to see if this medication is also helpful for women with ALD who have restless leg syndrome. So kind of going over this, a little bit more about this particular study. Who is eligible? Any woman with ALD who's over 18 years old. You can be asymptomatic or symptomatic. This is the first part of the study, and it's basically up to 3 interviews with our study team, including a sleep expert, RLS expert, our coordinator, ALD expert, and then we'll give you some surveys to complete to really get to know your symptoms. We are collaborating, and this is a multi-institutional effort here. And if you would like to participate, we are definitely still enrolling. We would like to enroll 100 patients, and we have about 54 right now, I think, or 53. Please contact our coordinators right here. I'm going to change the slide, but those coordinators will not go away. All right, so the goal of the second part of the study, the second phase of the study, is that in phase 1, we're going to identify which women actually have RLS. And then those women will be invited to participate in phase 2, in which we give them either pramipexole or placebo for a couple weeks. And then we actually swap, so the women will be in 2 groups. The first group gets placebo first and then pramipexole. And then the second group gets pramipexole first and placebo. And we don't know which woman is in which group, so it's blinded. But this is so that everyone can be on the treatment at some point, and we still have a control to see if this medication works. Okay, so what happens during this part of the study? Basically, you will be invited up to Boston, and we are going to randomize you to one of the 2 groups, and then you're going to get a neuro exam. You're going to do a lot of exams, basically looking at your ability to walk, do a sleep test to look at your sleep and look at any leg movements during sleep, and then we're going to have some surveys. So let me move on to the second part. So the second part, I'm going to be talking about gene therapy. I suspect most people in this room know the basics of ALD, so I will not bore you too much. But suffice to say that this is due to a mutation in ABCD1, which encodes a transporter that transports very long-chain fatty acids into the peroxisome so they can be degraded. The important takeaway here is that there are 3 manifestations of ALD. So there's adrenal dysfunction, but neurologically speaking, ALD affects the brain, and it can also affect the spinal cord. The brain disease we call cerebral ALD, the spinal cord disease we call AMN, or adrenomyeloneuropathy. Okay, so before I go into the specific gene therapies, I want to talk about the types of gene therapies. So there's 2 types of gene therapies on here. We're going to talk about them one at a time. On the left, you have in vivo AAV therapy. So AAV is the virus we use to deliver the gene therapy. In vivo means you deliver it directly into the CNS, into the brain, or into the spinal cord. This particular modality of therapy is used for AMN. And one of the biggest things to know about this particular type of therapy is that AAV goes into neurons, AAV goes into oligodendrocytes and Schwann cells, but AAV does not go into microglia, and that actually turns out to be something that's very important to consider. So we currently have a trial that's enrolling for adrenomyeloneuropathy gene therapy, and I'll go into that a little bit more later. Ex vivo lentivirus therapy. This is the other type of therapy. Lentivirus here is the virus that we're using for this particular therapy. This is used to target a childhood cerebral ALD. This is an indirect delivery because lentiviruses infect the hematopoietic stem cells and deliver the gene into hematopoietic stem cells. And this therapy specifically targets microglia because the bone marrow can produce all types of blood cells, including monocytes, and when the blood-brain barrier gets inflamed and the integrity of the blood-brain barrier breaks down during ALD, that allows the monocytes to go into the brain where they become monocyte-derived microglia-like cells, and so in that way we can target the microglia. Okay, so a little bit more about microglia. Why are we so interested in microglia if this is a disease that involves the oligodendrocytes and the Schwann cells that make the myelin? So this is very much simplifying things, but there are two main types of microglia. These are the resting microglia. So the microglia in your brain are like the white blood cells, the immune system of the brain. And they're always working, even when there's no infection going on. They're working to keep the brain healthy. And when you have an infection or when you have a metabolic abnormality, such as ALD, then they get activated, and these are activated microglia. And the job is to try to restore normalcy in the brain. But because of the genetic deficit here, the microglia are unable to restore normalcy. So why it's important in ALD is that we actually realized, Dr. Eichler published a study many years ago that showed that in ALD lesions in the brain, at the very periphery of the lesions, you actually have a leading edge of apoptotic microglia, which means microglia that are dying. So we know that neuroinflammation, which is what the microglia do in ALD, is also a big part of this disease. Hence, we're very interested in targeting the microglia. So again, just to drive this point home, the therapeutic cells here start out in the bone marrow. They produce hematopoietic stem cells that then turn into monocytes, and then that goes to the brain and turn into microglia-like cells. Okay, so we know that bone marrow transplantation works, and I'm not going to spend too much time on this because many people have covered this extensively today. This is allogeneic bone marrow transplant, which, as Dr. Lund pointed out, is a transplant using a donor that is not yourself, somebody else. There are some drawbacks to this particular type of transplantation. One, in that there's a search for a compatible donor. Not everybody has a compatible donor. And people who don't have immediate family members who can be donors, sometimes there's a long wait to search. And then the other drawback is that there's the chronic immunosuppression and graft versus host disease because your body is receiving foreign cells, so there's always going to be that immune response kind of against it. Okay, so we're getting around this with the gene therapy by doing autologous transplant. So auto means self. So in other words, you're using your own cells as a therapy. And the way we can do this is we collect bone marrow cells. Pointer died again? There we go. We collect bone marrow cells from the patient, and then they undergo gene therapy. So basically, the hematopoietic stem cells in the bone marrow, we then put the virus into the cells so that now these cells are expressing ABCD1 at very high levels. And once we have that, we actually give patients chemotherapy to wipe out their bone marrow that's diseased, create space, and allow transplant these corrected cells back into the patient. So these are the patient's own cells that are now expressing ABCD1 at high levels, and now they get that back in their body. So then the idea is that then the blood cells that are now expressing ABCD1 will then differentiate and engraft in the brain, turn into microglia-like cells, and basically affect the therapy there. So looking at clinical outcomes from our studies, how do we know this treatment works? And how do we assess that? So one of the things that we look at is the neurologic functional score. It basically is a measure of function. How well is somebody doing on a day-to-day basis? And these are the specific things that we look at. It's 25 points total. The higher the score, the worse the function. The lower the score, the better the function. And then in addition, we have something called major functional disabilities, which basically takes the 6 most serious symptoms, so the ones that are in bold here. And obviously, you want patients not to have any of these 6 major functional disabilities because these severely impact quality of life. So if you look at the children who received, the boys who received LE-cell or this gene therapy, the takeaway from this slide is that 94%, or 63 out of 67 patients, were able to achieve stable neurologic function without major functional disabilities. So 4 patients here, 1, 2, 3, and 4, did unfortunately end up getting major functional disabilities, but the rest of the patients did not. The other thing that we look at are imaging outcomes. So we can look at brain MRI to specifically look at the disease in the brain. So again, I'm not going to belabor this too much. We use the LESS score created by Dan Less that basically measures how bad the disease is in the brain based on how many areas of the brain are affected. And there's a specific list based on the different tracts in the brain that do different things in the body. So here, the myelin, so this is the brain, this is the skull on the outside, and in the inside is the actual brain. The dark part is myelin, so all of this is normal myelin, but if you come look down here, there's an area that's white, and that's disease. So this is a LESS score of 1, which means it's very mild disease, and this is actually the most common place where disease starts in ALD, in cerebral ALD. Again, this is a patient who has a LESS score of 15, so as you can see, the white is much more extensive, and this is much more severe disease. We usually consider advanced cerebral ALD to be a LESS score over 9. The other part that we look at in the MRI is enhancement. So here the white is contrast that basically shows you a breakdown in the vasculature, the blood-brain barrier in the brain. And so that's why you get contrast enhancement. And this is how we know there's active disease going on and something that we look for in terms of response to therapy. So if you look at the imaging outcomes, these are the 67 patients that were treated with LE-cell, the gene therapy. 90% were able to achieve a stable LESS score. That's basically defined as a score that's equal to or less than 9, so not advanced cerebral ALD, or less than a 6-point increase from the baseline. The reason we say less than a 6-point increase is that we know after the transplantation, it takes 12 to sometimes 24 months for things to actually truly stabilize. Okay, so this is a therapy that works, which is great. But as with any therapy, you have to weigh the benefits with the risks. And here, this gene therapy has now been associated with genotoxicity, which basically means toxic effects due to gene therapy. And in order to understand the genotoxicity, we have to understand how this virus works in delivering the gene into cells. So here, this is a lentivirus, and it can infect different cells, and it needs to infect cells to deliver the gene. So it attaches to the cell surface, and it gets transported into the cell. And this is the DNA that's encoded inside the virus that basically has the ABCD1 gene. You can see that it then gets, this is the nucleus of the cell where all the patient DNA is. And you have regular like native patient DNA in the light blue, but in the dark blue is where the virus will actually integrate into the patient DNA. And there are benefits and risks associated with this. So the advantages here are because the DNA is integrated directly into the patient's own genome, you get long-term expression, you get stable expression, And this DNA will divide if the cell divides, and the progeny cells, so the cells that come from this cell, will also express the transgene. The problems, the risks, are that it's hard to control where this virus goes in the genome. So a very large percent of our genome is what's called black matter. We're not really sure what it does. And if the virus hits there, it's less likely for it to be a problem. But if the virus integrates in a genomic region, or in a region that controls where genes are being expressed, or in a gene itself, that can potentially be a problem, especially if it's a gene related to cancer. And so some of our boys, I think 7 now, have developed myelodysplastic syndrome, unfortunately. So myelodysplastic syndrome is a hematologic disorder. It's a problem with hematopoietic cell production. So the hematopoietic stem cells in your bone marrow are responsible for producing red blood cells, white blood cells, and platelets. And when you have problems producing these different cell types, then you get symptoms associated with problems in these cell types. So if you don't have red blood cells, you get anemia, you get weakness and fatigue, difficulty breathing. If you don't have your white blood cells, you get frequent infections and your immune system gets really weak. And if you don't have platelets, it causes easy bleeding and bruising. So these are some of the symptoms that we look for. So this slide needs to be updated, I'm sorry, but here are 5 patients, 5 of the first patients who unfortunately developed MDS. So this is a lot of information in this table, so I want you to focus here. This is basically the time from when they got the transplant to when the patients developed MDS, or myelodysplastic syndrome. So you can see that this patient, the first patient here, developed MDS in month 92, which is, I think, about 7.5 years after the transplant. These 4 patients developed MDS much more quickly, like 14 to 42 months after the transplant. So this is actually quite a difference, and this kind of goes a little bit into MDS. So there's something called therapy-related MDS that we know patients who get chemotherapy can get. And we know this from a lot of studies from patients who have other types of cancers who get chemotherapies. So for example, in patients who already have blood cancers, they get chemotherapy to kill the blood cancers, but a few years down the road, usually 5 to 8-ish, Dr. Lund, correct me if I'm wrong, people unfortunately end up with therapy-related myeloid neoplasms like myelodysplastic syndrome. So this patient fits right in that category. This is about 7.5 years after the initial transplant. These 4 patients seem to have a sped up course. So what's the difference between these 4 patients and this one patient? It's that these 4 patients received fludarabine. So this is a particular chemotherapy that patients get and have been getting for many other disorders when they get transplants, to condition the bone marrow, which means wipe out the bone marrow cells so that the healthy bone marrow cells, the corrected bone marrow cells, can then go in. This patient, the patient number 1, did not get fludarabine, got cyclophosphamide instead. So do we know it's the fludarabine that's causing myelodysplastic syndrome? No, we don't. We suspect fludarabine is probably contributing given the significant differences between these 4 patients and that one patient, but we need to do a lot more studies to try to figure out, 1, if that's even true, and 2, what the mechanism is that's underlying that. The other thing is that all of these patients, as well as other patients who have not developed myelodysplastic syndrome, have lentivirus integrating in 2 particular places in the genome. One is called the MECOM, and the other is called PRDM16. These 2 areas have been associated with leukemias. And I should say leukemia is, so myelodysplastic syndrome is kind of the prodrome to leukemia. It's really just a number cutoff. So myelodysplastic syndrome, as it progresses, will eventually turn into acute myeloid leukemia. So we know that there's this association. But, you know, I don't think this is causative either, because we have kids who have integrations in MECOM who don't have cancer. So again, we just need to do a lot of different studies to really try to work this out. Okay, so takeaways from this. Microglial cell loss, open blood-brain barrier that allows the gene delivery from the hematopoietic stem cells, allows us to hijack the hematopoietic system to get gene therapy into the brain. And we know that this type of therapy works in the 70 patients that have now been treated with the gene therapy, as most of the patients, 94%, have stable neurologic function, and their LESS score is also stable. But unfortunately, the problem is that now we have to deal with these safety events that really make us reevaluate how we are tracking these patients and what information we need to learn more about this possible adverse effect. Okay, so moving on. How am I doing on time? Huh? Okay. 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 I'll be fast. We talked about the lentivirus therapy. We're going to talk about the in vivo AAV therapy. So in vivo AAV therapy, again, that's for AMN. This is targeting the spinal cord, goes directly into the CNS, as in it goes, or in the fluid that bathes the spinal cord, and therefore it goes to the spinal cord. Some of it might actually also get to the brain. But unfortunately, it does not treat the microglial problem. So I'm going to show you some preliminary data in mice. I will try to explain this to the best of my ability. So we work on a mouse model of ALD to do the preclinical studies needed, and this is true for every single therapy that ever reaches the clinic, is that we do these experiments in mice first to make sure that we can make it as safe as possible before we give it to humans. So for this particular study in the mice, we delivered AAV9, which is the vector that we use to deliver the gene therapy. And here, the AAV9 is not expressing ABCD1, but rather it's expressing green fluorescent protein, which fluoresces green. And that's because we can then generate these very pretty pictures to tell us exactly where in the spinal cord the AAV is going to make sure that the AAV is actually getting the gene therapy that we want into the spinal cord. So here you're looking at different slices of the spinal cord that's kind of coming this way. Okay, so you're looking at the spinal cord like this. And the green is basically the green fluorescent protein. So for low dose, you have less green fluorescent protein. For high dose, you have lots of green fluorescent protein. And that's great. That's what we expect. So, and that's just quantification, so I won't go into that. So the question is that also true for ABCD1? Because if it's true for GFP, it does not mean necessarily that it's true for ABCD1. It's just much harder to visualize ABCD1 in the spinal cord. So instead, we look at VLCFA level, very long chain fatty acid level. So lower is better. Wild-type mice, meaning healthy mice, have low levels of very long chain fatty acids. These are just two different types of very long chain fatty acids that we look at. And here, this is the control. So these are ALD mice that were not treated with any type of drug. They have very high levels of very long chain fatty acids, same here. And in mice that get the AAV, these mice here in both of these columns got AAV. One got it in a bolus form, and one got it as a slow infusion into the spinal cord. So you can see that the very long chain fatty acid levels definitely do not decrease down to wild type levels, but it is trending lower here and lower still here for this particular very long chain fatty acid. So then the question becomes, is that even clinically significant, right? Does that actually change the function of these mice? So ABCD1 deficient mice have symptoms like adrenomyeloneuropathy, AMN. They have symptoms that are due to spinal cord problems. So we took these mice and we actually delivered this virus expressing ABCD1 at 5 months of age and at 13 months of age here. Mice typically live for about 2 years. So these are mice. This is a very normal mouse. This is what their legs should look like, fully extended when you pick them up. This is slightly abnormal, and this type of clasping is extremely abnormal. So we basically grade the mice based on what they look like here, and that can tell us a lot about how their spinal cord is working. So if we inject the drug at 5 months, here the white bar, basically you're interested in the white bar and you're interested in the gray bar. The white bar is wild type, healthy mice. The gray bar is mice that have been treated with the gene therapy. And the black is ABCD1 mice that have not been treated. So basically you see the same pattern when injected at 5 months and 13 months, and this is very significant because mice are already symptomatic at 13 months, and it still has a therapeutic effect. Okay, last slide, I think. Okay, so we are having a clinical trial for men with AMN. We are injecting AAV, encoding ABCD1 into the fluid that bathes the spinal cord, and so this is basically where we're going in right here. It's a lumbar puncture. For all the women in here, it's basically like when you have a baby and they put, exactly. Okay, yes, an epidural. And this is how we do it. You basically are lying in a bed and we infuse the medication through your back there. And we are working with UMass. So that is in the works, and I'm going to be very excited to see what those results show. So hopefully at a future meeting that will, we will be able to share that with you. I want to thank all our patients, want to thank all our patient advocates, and all our collaborators here. I'm done.
Yeah, thank you very much.
Take a deep breath, change of pace, no big data here, just a nice, easy walkthrough. So deep breath, we'll get through here. So this is just a talk on trying to build the good life, and this was inspired by, I think, some difficult experiences and just we all face in life. You come up against an immovable object. How do you move forward? And the idea here is, you know, how can we move in the face of things we cannot? How do we move ahead in the face of things we cannot change? So the subtitle here, I put the polite version online, but this is, you know, building the good life, chronic disease be damned. Okay, so what is the secret to a long and happy life? And this is the ultimate question, right? All the therapies we use, we want to know, you know, does it do this? Does it do this? And then, does it make life better? That's the kind of the final thing. Like, we want to make life better, okay? You know, I critic of some of the things we do in other parts of neurology. You know, we do a good job here. But sometimes I feel like we're treating things that don't really make life better for people. And we are missing opportunities to really focus on the things that can make life better. And those don't even require, sometimes those are free. And this is kind of a focus on some of those things. So Ben's not here, but I had a question for him. So are there any Douglas Adams fans in the room who read Hitchhiker's Guide to the Galaxy? Does anybody know the answer to life, the universe, 42? And everything? Exactly. The answer is 42. So that is the end of the talk. And yeah, no. So the joke is there that is in Douglas Adams' world is that's the answer, and so they need to figure out what the question is. But here really is the question: is what is the secret to have a long and happy life? So, you know, is it money? Is it fame? Is it health? Well, the part is it luck? So this is, you know, we all have a kind of maybe our own ways of looking at this, and I would say it's relatively recent that people have really started to ask this. Science has started to ask this more rigorously. Well, what is it that really makes us happy? And this comes back to the kind of a gradual shift in ideas. It's not quite as dramatic as I put here, but you know, you've seen a doctor, you've talked about your problems, the doctor is going to focus on your problems, and it will really, when you go see that doctor, it will seem like you only probably have problems. The bigger view of life is that while there are problems, there are also strengths, and some of those strengths are things we can leverage even in the face of problems. And that is, I would say, one of the emerging philosophies of how we're approaching. And I would say many of the good doctors in this room are thinking about it, health in that way too. So in the past, we were sort of deficit focused. I would say we've been transitioning toward a more comprehensive focus on both deficits but also strengths. And so we want to go from just a focus on fixing the things that are ailing to also promoting the things that are flourishing. So I'm going to start with my favorite piece of advice here, and it's this one. This is if you're a fan of philosophy, I'm not really, but if you were a fan of ancient philosophy, the Stoics were philosophers who had a much more complicated view of virtues here. I just distilled my favorite pieces here, and my favorite piece is first figure out the things you can control, figure out the things you cannot, and let go of the things you cannot control, because I find that I personally fret over all these things I can't control, and it's not really doing me any good or anybody else any good. But then if we begin to focus on the things that we can, there are actually a lot of things we can control, and that's the focus of this talk, of the things we have control over, independent of our genes, independent of our age, independent of all the other things we don't have control of in life. This is about the things we can control. And then, if you want to extend it further, the Stoics focus on, mastering the self and learning to let go, all great things. But my favorite is really that first piece there. I find that there's just a lot of wisdom, and that's not as easy to figure out sometimes as you might think. And figuring that out and reminding yourself, okay, what do I have some agency over here, and what don't I? This is a full slide. I'm not going to spend the whole time on it. It summarizes the major findings in the field of positive psychology. In brief, the field of positive psychology is basically a field of focusing on psychological strengths for people. As you might be familiar with some of our psychological weaknesses: anxiety, depression, any number of things. This is more a focus. This is a relatively, unfortunately, new field of psychology in the past 25 years that has a kind of a distinct starting point around the late 90s. And it's really flourished. This is a really wonderful field, really interesting place. If you're a fan of podcasts, there's a podcast called The Happiness Lab that covers this. I think it's taught by a Yale professor. I'm a big fan. I recommend it to a lot of my patients and friends and family. But it's called The Happiness Lab. You check it out if you want to expand this more. The gist of it is there are a whole bunch of personal I would say this is sort of like exercise and healthy habits for the brain, of understanding what are the parts of the brain. It's almost like psychological anatomy. What are the pieces of our brain that do different things? This is a little more psychological, philosophical. And what can we control and focus on? So things that are big buzzwords in this area are, gratitude, optimism. Let's see, what are some other ones? Mindfulness. The term flow state is this sense of being, if you've ever been really immersed in something, so engaged in like a really good movie, or if you're a video gamer playing video games, or in conversation with a friend, or for the workaholics among us, really engaged in that thing you're doing at work, and oh my gosh, you're late for dinner. It's happened to me a million times. So but the flow state is this kind of continuous state. It's a very pleasant state for people. So self-compassion, others being patient with self. So there's an enormous amount of wisdom in this field that's slowly emerging, and these are people are really rigorously studying these. These aren't just kind of fancifully thrown out there, or so much as actually studied. And there's a lot of really interesting stuff here that I think we can all learn from. Here's okay, now to get into a little bit more of the nitty-gritty, but what do we really know about health and longevity? Well, who's heard of the Framingham study? Yeah, probably the most famous. This is like for the doctors, it's like the most famous longitudinal, meaning long-running, following people through a long period of time health study. we learned a lot of things about this that are just totally common knowledge now, that cholesterol and smoking and high blood pressure cause heart attacks and strokes. That's very easy knowledge for us now. But that wasn't 50, 60 years ago. And this isn't the graphic here, is a curve of the kind of the published findings and the associated decline in mortality rates associated with this. So this is progress. I mean, this is exciting stuff to see on paper. Life is really getting better for the average person, even though a lot of day-to-day stuff doesn't feel that way. So who's heard of the Okinawa Centenarian Study? Okay, well, some of you guys are really, okay. This is sort of a take on that looked at a very long-lived community on the island of Okinawa in Asia. And the takeaways here, I've summarized, but the takeaways were that a diet low in calories and rich in vegetables, high physical activity. This is actually just not doing, super high intensity stuff that all of these people who want to live forever are doing. This is just doing regular stuff, walking to the grocery store, walking to see friends. And then, oh, surprise, surprise, these strong social bonds are really important. People live in communities that talk to each other, and they know their neighbors, and they have friends, and they spend time with them, and they're not looking at their phones all the time. These are the really important components so this, I want to point this out because this is one of the things that I think you might have the most, might be a surprise to some people, but this theme of strong social bonds is one of the most consistent findings in all of the health and happiness and longevity studies. And so you'll see it over and over. So this is really, if you want to live a long, healthy life, call your friends, spend more time, don't call them, be with them and spend time with them and do real things for them. It's a really key part of things. So who's heard of the Mediterranean diet? Most of us have. So for a long time, this was just an observational thing. We said, okay, we think all these people in the Mediterranean are living really great lives, even though they're doing all these crazy things like smoking and drinking lots of wine. But this was formally studied beginning about 20 years ago, and it was a trial that was intended to last, I think, 6 years and 7,500 people, which is a huge study for those of us who follow randomized trials. And they stopped it early. And that happens sometimes for good reasons. The data people will say, listen, we got to stop early. You've got to signal. It means you're doing so well that there is no way you're going to, we can't continue this ethically. Everyone on the diet is doing so much better than anybody else. And so they stopped this study early. It was so helpful. So now this is mostly common knowledge, or I would say this is familiar knowledge to a lot of people. I wouldn't say common knowledge, but I'll highlight to the chagrin of many of us, notice that sweets are at the very bottom there. It says limit to 1 serving per week. So red meat and sweets. So, most of us go over that limit. I'm teasing a little bit, but the big focus here is just a plant-based diet with a healthy mix of grains and fish and other vegetables. So the 90+ study. I'll just assume Troy has heard of it and a couple others. This is based at UC Irvine, and I believe this one is focused on a really unique group of people. I think at Loma Linda, there's a Seventh-day Adventist community there that has really long-lived group of people, and so people have studied, well, how are these people living so long? Why are they so healthy? What are they doing? Again, social engagement. They actually have no alcohol intake and physical activity. So social engagement is one of the big themes here. And who's heard of the Harvard study of adult development? So this is also commonly known as the Harvard happiness study, because they've started to shift to So famously, John F. Kennedy was included in the original cohort for this study and was one of the people. And this was started back in the 30s. It's been going on forever, and they've been tracking all this data on people on the kind of original cohorts of people coming out of Harvard, and I forget exactly which class it was, whether it was a class of 38 or something, and they tried to follow them over these many years and figure out who thrived, who didn't. Tons of people were very successful, tons of people failed, and what made their lives good and bad. And I love this quote from the person who is, I think, most recently leading the study. They've had many PIs. It says, the people who were happiest, who stayed healthiest as they grew old, and who lived the longest were the people who had the warmest connection with other people. Again, we have a little bit of choice in this, right? I mean, you can choose whether or not you can choose not to spend less time on your phone and less time, just holed up in your house watching Netflix. And you can, really, this is a call to be out with people. My advice to mostly teenagers who I see in my clinic is, spend time with your friends in real life doing real things, and that's a great way to do things. Believe it or not, you might enjoy that a whole lot, even though you might. There's actually this famous finding where people tend to dread certain activities, especially the social engagement, because they think they're going to dislike it. And famously, they, in every capacity, whether it's just chatting with a barista, chatting with somebody in line, they all think, I don't want to do that. They all feel better afterward. And and this is one of my favorite reasons to sort of bet on humanity in the long term, is we're wired for this. We're really wired to spend time with other people. We're wired to be good to other people and to talk to other people, engage with people. So it's a really thing. Believe it or not, people often like being engaged, and so even strangers. You can maybe recall some moments where somebody's really nice or just said something polite or made polite conversation. It's not always what we want. Certainly not for hours and hours on end if you're sitting on a plane, but a little bit of engagement is just nice. It's really pleasant. So social connection is we study. The scientists are studying individual neurons. There's a real case to be made that we are big neurons and we need engagement. We're kind of wired to connect and fire it and work with other people. Okay, now who's heard of the Blue Zone Project? This one's a little more popular, but I think of it. So this is not really a scientific study. So I put it last year, but I think so. This is these blue zones. The term came from just that happened to be the color of ink they were using to mark the spots on the map where people were living for these very unusually long periods of times. And then people have begun to say, well, what is it that all these communities are doing? What makes them so unique? Why are people living to be 100 and 110 in these communities at such frequencies? So there have been many studies of different kinds. It's not one study, but there was a really neat journalist who's very likable. I recommend this if you're. Most of us have Netflix. It's a Netflix documentary. It's like 5 episodes of 40 minutes each. It's called, I think, Live to 100 or something. It's wonderful. It's very upbeat. It's so happy. The gentleman's name is Dan Buettner, and he was a journalist, and I don't know what his other background was. He had kind of a colorful background. But he worked for National Geographic, and he happened to visit one of these communities, and he loved it. And he said he has since kind of dedicated his life to exploring it and trying to help people understand, and really has done a good job at publicizing it. This is my favorite study. This is, there's that old riddle of, if a tree falls in the forest and nobody hears it, doesn't make a sound. Well, there's a lot of science, great science that gets done that nobody knows about, and it doesn't matter because nobody knows. And this is kind of popular, a little fluffier stuff, maybe not as hard science, but it's all themed and consistent with the literature. And I love the way that this gentleman's published it. He's written quite a few books on it. This is a neat, approachable sort of thing. If you're interested in sort of understanding what makes life good and so on, this is good. And this is their little graphical summary here. So, it's be active, spend time with people, eat a healthy diet, kind of thing. So these are, you might sort of get the sense here that there is a theme to these things. There are a finite number of things that seem to make a really big difference for life. And I put the things on the left here that I think you already know. I put the things on the right that are things that you may not know, but are really, I think, exciting and interesting. And some of the neatest areas of emerging science are in these spaces where, again, this is irrespective of any of the other things that people face in their life. There's a lot of sort of ability to sort of say, okay, I've got all of this stuff going on, but these are the things I can change, and these are the things that, I can't change this, but I can focus on this, and I can help make this part of my life better. And the neat thing is that making life better for other people often makes life better for you. So that's a very hopeful note I'll end on. I don't have much to say beyond that, but I like this quote too, so I put in here: health is a state of body, wellness is a state of being. And I'll close there. I don't think we really have time for questions, but I'll take questions afterward. And thank you.
Thank you very much, Keith. You actually saved my day.
Yeah. So but I think Ben's here now. So Ben, earlier I had a slide up here. So the slide was, what is the secret to life, the universe, and everything? What's the answer to life, the universe, and everything? Do you remember from the book? What's the answer? 42, right? So who knows? Yeah. Okay. All right, guys.
So very good. So I think we had a nice meeting, very dense meeting, and a lot of information. But I think that's why you are here, and so we hear new things and things that makes us a little bit of hope. New treatments coming up, and a new behavior for well-being and so on. So I think all the speakers today very much. I think the Adrenoleukodystrophy Foundation, and thank you for the discussions. And I wish you all a nice evening and a good meeting.